Check, check. 1, 2. Checking audio to records.
Everyone. Today is Sunday, and I'm so thankful everyone made it here safe. I'm born and raised in Washington, D.C., so I didn't have to travel, just traveled from the D.C. side and made my way across the bridge to Virginia. My name is Essie Graber. I'm a stage 4 cancer patient, stomach cancer patient. I was diagnosed in November 2022 with no signs or symptoms or anything, just went in for a routine colonoscopy. And when my doctor finished the test, he said, "Your colon looks good, but I see something on your stomach." And that was the most devastating news I heard since November 2022. Fast forward from that, I did FLOT4 chemo, 4 rounds of that. Then I had partial stomach removal in April 2023. Then I did FLOT4, again, 4 more rounds. Rang the bell, had tests that showed that I was NED. So that was the most happiest news I heard since 2022. And then 1 year later, here I am. It came back. I had a reoccurrence, so I'm on a clinical trial right now. And I just found out last week with a recent PET scan I had that the tumor has increased a little, so I'm going to be starting on another treatment soon. So that's my tidbit in a real quick shell. I'm just so happy to introduce this next speaker we had. I had an opportunity to work with her. Well, not work with her. Well, she was a social worker on a support group that I've been a part of since actually December 2022. We had one social worker, and then she left, and then Jocelyn came and just felt right in the shoes of the other social worker. So I'm just so excited, and I got to meet her personal at an event that we had that's right here in DC, and so I'm going to introduce her with her bio. So Jocelyn Travati is an oncology social worker at the George Washington University Cancer Center, where she provides emotional support and resources to people with cancer and their caregivers. Jocelyn earned a master's in social work from the University of Pennsylvania and a bachelor's in psychology from the George Washington University. Jocelyn is thrilled to be attending this year's Patient Empowerment Summit and is grateful for the opportunity to participate. Please welcome Jocelyn. And I did forget to thank all our sponsors that's a part of this program that have sponsored, and the Wi-Fi is in our book. All right. Thank you so
much. Good morning, everybody. Can you hear me? Yes. Okay. Apologies in advance for the hoarse voice. I'm just getting over a little bit of a cold. All righty. Well, it's wonderful to be here. As Essie said, I'm an oncology social worker. So I work with people of all ages and their families as they navigate cancer treatment. At any point in their diagnosis, whenever they need the warm touch of a social worker, that's where I come in. I have no financial disclosures to report. So just a few objectives for my presentation. We're going to talk about who is the AYA, or Adolescent and Young Adult Cancer Community, and talk about their experience. We're going to identify challenges that AYAs with cancer may encounter, and we'll discuss how social workers like me address barriers that AYAs with cancer might face. So this is a little bit about me. I'm an oncology social worker, have been for about 4 years now. My role primarily is to meet the person with cancer, learn about who they are and what's important to them. There's not a one-size-fits-all approach to what I do, so I often will meet patients at one of their first appointments with their provider, learn about their values, their goals, what's important to them, and how I can support them. And it doesn't just extend to the patient or the person with cancer. I tend to use the term person with cancer because a lot of folks don't like to be defined by being a cancer patient. But my support doesn't just start, or it only starts with the person with cancer. It extends to the people that love them as well. I also facilitate support groups. As Essie said, that's how I met her and had the pleasure of learning her story. So I offer a space for people to come together and talk about their shared experiences around their cancer. And then I help with finding resources, and that can look like anything, things like transportation, financial assistance, getting fresh food in the fridge, helping folks enroll in public benefits like Medicaid or SNAP, and much, much more. Basically, if a patient has a question, or if a person with cancer has a question, I try to help them find an answer. And of course, I work alongside the oncologists, physician assistants, nurse practitioners, nurses, medical assistants, dietitians, basically anyone in the cancer center that's involved in patient care, I'm talking to make sure that we're working as a team. I know it's very frustrating when people in treatment feel like they have to repeat themselves to all different care team members. So I want to be sure that we're all talking to each other and making your experience as the person being treated as simple as possible. Now, a little bit about me. 6 months into my oncology social work career, I found out I had cancer. I didn't go into this work because I had cancer. I had no idea. So imagine my surprise to be both providing support to people with cancer and then to become one. Now, I'm happy to report that I am going on 3 years of no evidence of disease. So that's a wonderful thing. Thank you. But that obviously was, a wake-up call. It was a moment where I had to reflect on what I needed as a person with cancer, whether I could balance the work that I do and my own, my own needs. And with the support of friends and family and my coworkers back when I was in Philadelphia, I managed it. I found a way through. So I'm very grateful to be here today and to tell that story. So, who is an AYA? So when I say AYA, that stands for an adolescent or young adult person with cancer. There are different age ranges, but typically the one that I see the most is around ages 15 to 39. This is a person living with a cancer diagnosis. It can be at any stage, in any part of their body. This is a period of time where people are going through significant physical, emotional, and social development. So they may be in college and, pursuing a first degree. They may be starting a career like I was. They may be, having just gotten married and thinking about starting a family. So to be at these crucial developmental milestones and to have a cancer diagnosis handed to you can be earth-shattering. Cancers in adolescents and young adults are often more aggressive and diagnosed at later stages. That's just a common fact among young people with cancer. And so what are some of the main concerns for AYAs with cancer? Some of the things that I encounter most with the folks that I work with: body image, intimacy, fertility, financial concerns. As I mentioned, personal and developmental milestones. I'm curious if there are any others that I missed, and I should have said this earlier, but I want this to be a conversation, so please feel free to raise your hand and contribute anything that you feel like I've missed. Okay. So body image, I think, is one of the concerns for AYAs that comes up the most. We know that treatment could involve surgery, chemotherapy, radiation, immunotherapy. And these treatments come with any number of side effects and things that can either be short-term or long-term. So we know that with AYAs in particular, body image can be a really big thing. Hair loss is a huge thing that folks with cancer, especially young folks, struggle with. In my role, I help people navigate, what that means. What does your body image mean to you? What does losing hair mean to you? How can we make it so that you're most comfortable going out into the world? Does that look like a wig? Does that look like a scarf or a hat? Does that look like maybe nothing at all? It's a very individual process, and as I said earlier, there's no one-size-fits-all approach to my role as a social worker in providing care. So I'm really there to make sure that you have what you need to feel safe and comfortable, even though you've been handed this diagnosis that you didn't ask for. Weight fluctuation is another thing that we see a lot. That can mean, extreme weight loss. That can mean weight gain. A lot of these medications can cause weight gain, and that can cause, major emotional distress. So that's in a situation where I would work with a dietitian to see what, avenues we can pursue to ensure that you are most comfortable. Intimacy. Now, this is another pretty heavy and sort of taboo topic, and, intricately linked with body image. We know that this is something that's hard to talk about with our partners, with our providers. It just doesn't feel the most comfortable. But my role as a social worker is to say, hey, I know this is something that doesn't feel like the most friendly topic. It doesn't feel like something you can chat about with friends and family. But it's important to know how cancer is going to impact this part of your life. We know that pain and fatigue can play a role in intimacy. Diminished sexual desire may come into play. And yeah, it's a stigmatized topic, but it bears discussing because it is an important part of a lot of people's lives. Now, fertility. This is something that I've taken a particular interest in just because I feel that there are so many gaps in discussing fertility among AYAs who have cancer. I was fortunate that with my own oncologist, one of the first things that we talked about was fertility. She said, at that point, I didn't know what my treatment regimen would be. There were a number of options for my diagnosis, but she said, if you choose chemotherapy, that may impact your fertility, and that if that's important to you, then you should pursue fertility preservation. And that can look like different avenues for treatment, whether that's egg freezing or sperm banking or IVF or IUI or any number of options. But it's important to talk about, especially at this phase of life, being an adolescent or young adult. If having a family means something to you, then these conversations need to be had, and they don't always happen. So we do see sometimes an incomplete or a lack of information about fertility preservation prior to treatment. We also notice the psychological burden of having to make these decisions so quickly. I mean, people spend years thinking about whether they want a family, and then all of a sudden you're handed a cancer diagnosis and you have to decide within days to weeks what you want to do as far as bringing other people into the world. And of course, this goes without saying, but there's a financial burden. Some insurance does cover fertility preservation, but not all. And if there is coverage, it's often not comprehensive. And if you receive state health insurance, there is no coverage. Now, the majority of my patients at GW Cancer Center have Medicaid, have state health insurance. So if you're a young person with Medicaid and you are handed a cancer diagnosis and you want to think about, okay, well, I want to plan for a family, you're often left with little to no options in terms of paying for these kinds of treatments. And there are grants out there, but, it can be tricky to sometimes get them when the grant window opens, and is it enough coverage? But that's something I help folks navigate. And then, of course, looping into fertility and things like that is our financial concerns. AYAs might be at the start of their career or still in school. They might not have tremendous savings. Treatment may require a lot of time off work or having to leave your job completely, and that can open the door for a lot of uncertainty. Insurance may not fully cover treatment costs. And I'm not just talking about fertility. I mean, I'm sure you all know that, cancer treatment can often come with thousands of dollars of out-of-pocket costs that the patient is left to be responsible for. And that can be the difference between, keeping your lights on, getting your medications, keeping food on the table. There are tremendous financial ramifications that come with cancer. And of course, as I've said before, in this stage of life, there are very important milestones in terms of education, career, and relationships. when I think about how to address a patient or a person with cancer who's an AYA, I think about the social determinants of health. That may not be a term that's familiar to everyone, so I'm just going to read the definition. So social determinants of health are the non-medical factors that influence a person's health outcomes. They include the conditions in which people are born, where they live, how they learn, work, and play, and their age, as well as the wider set of forces and systems shaping these conditions. So I try to think about a person with cancer as a full picture, not just the person and who they are sitting in front of me, but what factors might impact how they've gotten in front of me today. And it comes down to the very minute things like, are they getting to their treatments? Are they getting to their appointments by car? Are they having to rely on public transportation? If they're relying on public transportation, is that going to be a safe and healthy avenue for them to get to treatment? Is their housing and living situation safe and stable? Are they living with people who are supportive of them as they undergo treatment? Are they living alone, and does that present challenges? What has been their access to health care before getting here? Have they been able to receive regular primary care and dental visits and sexual health visits? And who's looking out for them? Are there friends and family that are coming to these visits? Are they sharing with their community what's going on with them? Are they asking for help? If not, why? And there may be very valid reasons why a person decides not to share what they're going through as far as their cancer. But I'm certainly always a proponent of the more the merrier. So, where do I come in? How do I help an AYA who has cancer make this process as simple and, relatively speaking, painless as possible? So, as a social worker, my primary goal is to establish a trusting relationship with an AYA. I often say I'm going to be the one person on your team that's not poking and prodding at you, but I am going to challenge you to look inward and to see where there are ways that we can open you up and give you the support that you deserve. We don't shy away from naming the unique struggles that AYAs face. Now, I don't need to tell anyone here that at any age, cancer comes with enormous challenges. But I do think, given that cancer tends to affect folks who are in their 40s, 50s, 60s, 70s, there are often conversations that don't take into consideration younger people and the unique struggles that they might encounter with a cancer diagnosis. We invite discussion of difficult or uncomfortable topics without shame or judgment. We strongly encourage connection with other AYAs living with cancer, and I'll come back to that because there are definitely organizations that bring folks that are young folks with cancer together. We outreach to partners, parents, or other loved ones who can collaborate in supporting the AYA. A big part of my initial meeting with the patient is who's important to you, who's going to be looking out for you. Is that someone you want me to talk to? Can we attack this as a team? We provide resources to aid in body image recovery, like wigs and scarves, as I mentioned earlier. And as available, we can provide financial assistance or help people navigate to organizations that have grants and things like that. There are many, many resources for people with cancer of all ages out there, but I wanted to highlight a few here. Now, of course, the reason you're all here today is because you have made a connection with Hope for Stomach Cancer. So certainly continue to stay connected. There's Debbie's Dream, the Gastric Cancer Foundation, and No Stomach for Cancer. There are some AYA-specific resources like Stupid Cancer, Young Adult Survivors United. Elephants in Tea is actually a magazine where people submit their personal stories about their experience as an AYA with cancer. One note I want to make here is that, and this is actually a mistake on my part, the Young Survival Coalition is a breast cancer-specific organization, so I would stick to the other three. Some general cancer resources include Cancer Support Community, which is where I had the pleasure of meeting Essie, and this is a national nonprofit organization that offers support groups, individual counseling, lifestyle events, educational programs to anyone with a cancer and their families. A few others are Cancer Care, Immerman's Angels, and My Cancer Connection are peer support organizations. So these organizations link people who have a cancer with someone else who has the same cancer or a similar diagnosis so that they can support each other. And then one thing that I think has been really special in the AYA cancer space are cancer retreats, an opportunity to have a change of scenery, to have a new experience. First Descents is one of the bigger organizations that are offering trips for, I believe they offer trips for young adults with cancer, young adults with MS, and healthcare workers. And I had the pleasure of going on their whitewater kayaking trip to Montana, which was, I'm not a whitewater kayaker, but I had a great time. I also went on a trip to beautiful northern Michigan with the Cassie Hines Shoes Cancer Foundation. Epic Experience is another organization that provides really fun outdoorsy trips across the country. So that one I think is fun to look into because sometimes we just need to be in a totally separate environment and around people who understand the experience of cancer. Financial assistance. So this is among one of the trickier parts of my role as a social worker. There's never enough financial assistance, I'll say that. But there are organizations that are trying really hard to provide support to folks who are managing really high out-of-pocket costs for treatment, who are having to balance rent, utilities, groceries, childcare. There are a lot of organizations that know how heavy the impact of these financial burdens can be. A couple of those are Cancer Care and the Assistance Fund. Now, of course, it's worth noting that at any point, any of these organizations may not have funding at that time, or there may be various application requirements. Those are all things that, as a social worker, I can help you work through. Of course, I'm always going to advocate that you reach out to your cancer center social worker because they're going to be the one that will know what's available in your cancer center and can help you find other outside resources. Triage Cancer is an amazing organization that help people answer complex questions about legal and financial concerns related to cancer. They have an amazing library of resources on their website and workshops. They can help you navigate really any questions related to finances, legal issues, work. They're an amazing resource. And then for fertility, there are a number of different grants out there, but again, it really depends on what time of year you're applying, which of course can present challenges if you need to get fertility preservation done right away. You may have some difficulty finding ones that are available at the exact moment that you need them, but a couple that I have found pretty reliable are Team Maggie's Dream and Verna's Purse, and these organizations offer financial assistance for covering fertility medications, covering fertility procedures like egg freezing, IVF, IUI, sperm banking, and storage as well. Verna's Purse in particular covers storage for eggs and sperm, as well as embryos. I know I've covered a lot of information here, and I would love to hear any questions that you have. Essie has the microphone, so if you can just raise your hand, she'll bring it over to you. But thank you so much for listening, and I'm happy to hear any questions.
All right. Do anyone have any questions? All right, got somebody back here.
Thank you. My question is, are these services available for young adults that have the hereditary gene or some sort of hereditary predisposition to cancer? Or do they have to wait till they get cancer? And the reason I ask is because I have 3 children. We have cancer in my family.
Yeah.
And I'm struggling with my children getting tested.
Yeah.
They have a fear.
Yeah. What I will say is that there are not nearly enough resources for folks who have a hereditary predisposition to cancer. I'm sure you know that. I can think of maybe one organization called Force that offers support and resources to folks who have a hereditary predisposition to cancer. I will say largely, and this is unfortunate, that these services generally do apply to folks who have a cancer diagnosis. However, as a social worker in a cancer center, if one of the providers that I'm working with is treating someone with a predisposition, by no means am I excluded from being involved in their care. So if they need someone to talk to, if they need a listening ear, I am absolutely there. But yes, a lot of these grants and services are, reserved for folks who have a cancer diagnosis. But you're definitely highlighting a gap in this field, absolutely. Thanks for the question.
Jocelyn, I wanted to ask a question. Are these services just for GW patients or
No.
anyone?
All the services that I've talked about are open to anyone. Now, of course, if it's like, for example, GW does have a financial assistance program. We can help with parking passes and Uber and a couple other things. So that would be if you're a GW Cancer Center patient. But any of the other organizations that I mentioned are open to anyone. Anybody other questions?
I was going to ask a question. What are some ways that you engage AYA? Because I know with my organization, Man After Cancer, we do have men who are younger with cancer, and the hardest thing is getting them to engage. Yeah. A lot of them don't even want to talk to another cancer patient because they don't even want it in their mind. They want to deal with what they should be dealing with as a young adult and not cancer.
Yeah.
So just getting them to even talk about it and engage with one another, is a struggle for us as an organization.
Yeah, that's a great question. I think you certainly have to meet people where they are. If someone is ready to engage and wants to connect, that's great. Sometimes that's not going to happen at the first appointment. Sometimes that's going to take, days, weeks, or months to feel like, okay, I really need someone else to help me relate to this. I think it's no surprise that young people, or lots of young people, like to connect on social media. That has certainly been a big part of my personal experience with cancer, has been finding communities online of people near and far who understand the experience of cancer and can relate and can find, some dark humor in it, can laugh about the not so pretty side effects, can laugh about giving you Benadryl at your infusion and passing out before they even start your medication. I think a lot of it is just finding what works for you. And it's also okay if you or someone who deals with things independently. We can't force connection, but I do find that for the vast majority of AYAs that it does bring solace and comfort.
Awesome. Yeah. Thank you.
Thank you.
All right, we got one up the front.
I think we have time for
we have
one or two more questions.
Okay, here we go.
So my late husband was diagnosed when he was in his 30s, and we had young children. So I do think that, resources for how to talk to your children about your cancer, depending on age, or even, finding out about local support groups or camps or different things for children of cancer patients would be something that would have been helpful. Yeah.
Absolutely. Thank you. And that's something that I regularly help my patients with. And there's actually a whole lot of, I want to say literature because that seems a little highbrow. There are a whole lot of great books written by, independent authors and also by organizations like Cancer Support Community and the American Cancer Society that are tailored to talking to kids from different age groups about a parent's cancer. Or about a parent losing their life to a cancer. And that's something that I'd be happy to share more with you about if you'd like it. But thank you for bringing that up.
Hello.
Hi.
Wow, it's loud. My question is, do you have, or do you work with people that are survivors as well, with things such as like survivor guilt sometimes, or just the general paranoia of it coming back and, when is it coming back, or things like that, or do you have a list of organizations that do that kind of thing?
Absolutely. Yeah, my work with people with cancer doesn't stop when they've gotten the all clear, when they're told they're in remission or NED. because we know that the journey with cancer doesn't end there. Follow-up is an integral part of cancer care. We know that cancer can come back. We know that there are innumerable unknowns. So yeah, absolutely. I do work with folks who are survivors. And resources for that, that's something that I should certainly look into more. But yes, absolutely. I mean, I hear patients talk all the time, especially when they know other young folks with cancer who were not able to be cured and who did lose their lives, that, you know, why did I survive and this person didn't? It's incredibly painful to both feel grateful that you were able to reach remission, that someone else you cared about didn't. Thank you for highlighting that. Well, thanks so much for joining, and I'm looking forward to connecting with you after this.
All righty. Thank you, Jocelyn. We truly appreciate you coming to speak with us today. My granddaughter have a question, but I didn't want to put her on mic. All righty, well, we're going to close this part out. We have lunch out there, and then we're going to have a Q&A with Jocelyn during lunchtime in the room that we were in for breakfast and for lunch. 1 p.m. back in here. All right. Lunch is available. Yes. Jocelyn, you're welcome. Jocelyn.
Did you have a question? Who had a question? You did?
Recording in progress.
It just worked? Strange. Okay. No problem.
Yep.
Good afternoon. My name is Alicia Aguirre. I was caregiver to my husband, Mark. We were married for 25 years. He was diagnosed in August of 2018 and unfortunately passed away in April of 2020. I'm really happy to be here today and to be able to introduce Dr. Riem as an associate professor from the Department of Surgery at Columbia University, Irving Medical Center in New York. Her lab is focused on gastroesophageal cancer, from basic mechanisms to preclinical studies driving therapies forward for FDA approval to enter clinical trials. Her work as the scientific director of the Torrey Coast Foundation has allowed her to drive new target discovery and the generation of testing of new therapeutic modalities for GEA cancer. Unfortunately, Dr. Riem was not able to be with us in person today, but we are lucky to have her joining us via Zoom. Thank you, Dr. Riem.
Hi, everyone. Thank you so much. Can you hear me? Alicia, can you hear me?
Yes,
Okay,
we
great.
can.
Thank you for the introduction, and I really apologize. I had a medical emergency with my daughter, and so I had to come back, and she was in the hospital. She's okay now, but needed me. So I'm glad to be able to be here by Zoom. Thank you guys all. I'm going to share my slides now. And great. Okay, great. So Alicia introduced me, my role at Columbia. My lab's really working on preclinical models to drive therapies to clinical trials. And I'm fortunate to be able to work with the Torrey Coast Foundation to really help move the needle on new therapeutics for stomach and esophageal cancer. And so I wanted to talk to you all and share a little about some of the work that's going on, not just in my lab, but in labs around the country through the generosity of the Torrey Coast Foundation. So this slide, many I know are aware of, and I just wanted to very broadly talk about where we are in terms of current therapeutics. So if you put stomach cancer in two buckets of local, meaning just confined to the stomach or confined to the stomach and lymph nodes surrounding the stomach, therapy begins with surgery and then chemotherapy. And then this other bucket, which is unfortunately more common, is this advanced disease where it's spread too far to be able to make surgery an option. And right now, these patients are treated with chemotherapy. And then there are three different, what we call biomarkers, which I'll talk about a little bit more in a second, HER2. So it's a protein that's expressed on some stomach cancer. So if you have HER2 expression, you'll get a drug added to your therapy called trastuzumab, which binds specifically to HER2. If you have a PD-L1 score, anywhere from 1, 5, 10, you'll have something called an immune checkpoint inhibitor, which is pembrolizumab, might be a name many of you are familiar with. And then most recently, in December, FDA approved a new biomarker, and this is a protein called Claudin 18.2. And then you have zolbetuximab added to your treatment regimen. And this is a drug that binds specifically to this protein, Claudin 18.2. And so I've also worked with No Stomach for Cancer, and I know Hope for Stomach Cancer has been working on this as well, about really educating families, patient advocates about testing biomarkers. So when someone is given a diagnosis of stomach cancer, it's really important for that, the patient and the family to ask their caregiver to test for the biomarkers. So we know what kind of cancer and how personalized we can treat the patient. So if you start here at this patient, you can give either blood or a biopsy sample. And then there's lots of different molecular analysis, which I'll talk about a little bit, to be able to do the data analysis and then identify what kind of biomarker do you have, which means what kind of protein is expressed on top of the cancer cell or within the cancer cell, which will help us personalize treatment for the patient. And so this is a busy slide, and you can ignore these words mandatory and emerging, but these are some of the biomarkers that are currently either done routinely or done experimentally because there's new therapies that are on the horizon. So on the left here, HER2, which I mentioned, you can test this, and this is these blue things are the cell, and the proteins are expressed on the surface of the cell. PD-L1, which I also mentioned, and relates to whether you get immune checkpoint inhibitors. And then MSI high here on the bottom is also a way to look within the cell to see whether the tumor cells might be responsive to another type of immune checkpoint. And then Claudin 18.2 now can be moved over to this side, and you would get the drug zolbetuximab. But here's a whole bunch of others, none names that you necessarily need to remember, but this knowledge that it's expanding all the time. So KRAS is a new biomarker, and there's now a drug that will target this. And in stomach cancer, KRAS is a gene that's often amplified, meaning there's more than 2 copies. There can be 7, 30, 100 copy. And there are drugs now in phase 2 and phase 3 clinical trials in other diseases, notably pancreatic cancer, that's showing a lot of efficacy for targeting this protein called KRAS. So if we know what the tumor is expressing, there's a lot of drugs that are in phase 2 and 3 trials that patients could be eligible for. So very important to get your biomarkers tested. FGFR2 is also another protein that I just wanted to mention. It's in phase 3 trials showing some efficacy, meaning the drug that's being tested is showing some response in patients who express high levels of this protein FGFR2. So one of the things we've been focused on in the foundation is, we want to know, are there new targets that are expressed on stomach cancer cells that we can develop drugs to? So I just talked about things like KRAS, FGFR2, HER2, but we think that there are others. So there's a large effort by groups at the Broad Institute, at Dana-Farber, at Harvard, who have really advanced experimental techniques to look for new proteins that are expressed specifically on stomach cancer. So there's 2 ways they do this. One is by using AI and machine learning and taking all the sequencing data we have to identify proteins that are specifically overexpressed or expressed only on stomach cancer cells, but not on normal cells. And the other is an experimental approach. So they can take stomach cancer cells and basically label it, right? Like label every protein on there and compare that to a normal stomach cell, and then figure out which is specific to. So we have a lot of new targets that have been coming out in the last month that we're really excited about developing drugs to. So some of the criteria as highlighted here are proteins that are expressed on tumor cells, but not on normal cells. And also we want proteins that are expressed on a significant number, not just one of the tumor cells, but 50% or 70%, a significant number, so that any drug that we develop, and I'm using the royal we, this is a large number of labs and groups around the country and actually around the world as well, it has a better chance of working. So this slide, also very busy slide, But what you can see here is this is a T cell on the left side and the stomach cancer cells on the right side. So these are all drugs that target, as you can see, cells that sort of on the surface. So, or stick out of the surface. So recognize. So there's a whole class of drugs that target pathways and proteins inside the surface. But today I just want to talk about all of the proteins we're targeting that are expressed on the outside of the cell. And there are specific treatment options or drugs that I'll get into next that are targeting outside cell. So the drugs that are circled in red have all been approved by the FDA. So Claudin 18.2, 2 different types of HER2, another protein, and then all these other drugs are things that are in phase 1, 2, or 3 clinical trials. So depending on how they turn out, and they can either target the stomach cells or the T cells. So I wanted to share with all of you today is some of the efforts in new drug development. So using some of these known targets and some of the new targets that are coming out from these groups doing those experimental approaches, there are 4 classes of drugs that I just wanted to go over today and share our thoughts and ideas. And I think the beauty is that all 4 of these approaches are being pursued simultaneously, which is the way we need to do this to really move the needle and to get to clinical trials quickly and to get to patients quickly. So I'll talk about all 4. The first is something called an antibody drug conjugate, and it's often referred to as an ADC, and I'll get into that. The second is a chimeric antigen receptor T cell therapy, referred to as CAR-T. A newer class of drug is called Radiopharmaceuticals. And then the last one is cancer vaccine. So I'd like to briefly just share what all these 4 different treatment options are and what we're doing now in that area for stomach cancer specifically. So the first one is something I mentioned called antibody drug conjugate. So the antibody here, this Y-shaped structure here, is the part of the drug that recognizes the protein on the cell surface. So once we have the identity of a protein on the stomach cancer cell, we can make this. Then we put some molecules in here to link it to something what we call the payload, which is basically chemotherapy. And so you can see how this would be very different from just systemic chemotherapy, just given, in the blood, which kills any dividing cell. So this we think is much more specific to the tumor cell. And we actually already have this in clinical trial or approved by the FDA. And this is a drug called Enhertu. So it was an expanded or a modified version of trastuzumab. And I mentioned HER2. Many of you might be familiar with this. So when HER2 is expressed on stomach cancer cells, it is also expressed on breast cancer cells. But when HER2 is expressed, then this antibody, trastuzumab, binds it and kills it. But the ADC now has a chemotherapy drug attached to it. So this antibody chemotherapy drug will go directly to the cancer cell. So there's no or much fewer side effects in theory. So once it binds to the cancer cell takes it inside, and then the chemotherapy drug is released. So that linker is really important because we know how to separate the antibody from the chemotherapy, and then it kills the cancer cell. And we know actually if you compare Enhertu, which is the ADC version of trastuzumab, it's more effective than trastuzumab. So in the Destiny Gastric 1 clinical trial, they showed that stomach cancer patients who had progressed on trastuzumab showed a response rate of 51%, suggesting that there's more specificity, more local killing. So we're really excited about this option, and we are now developing these ADCs to these new targets that I talked about experimentally. So there's a handful of new targets that we think, so if you don't have HER2 and if you're HER2 negative, we're hoping that one of these other targets will be expressed, that we can use these ADCs and show some efficacy for treatment. The next class of drugs is a chimeric antigen receptor T cell. So this got a lot of press many years ago. So this is when we take the T cells out of your body, manipulate them with something called the chimeric antigen receptor, and then we put it back in your body. So it's a very personalized treatment. So what's not personalized is the actual receptor. So here's a T cell, and what we do is, this is the receptor. So what it does is we have this receptor binding to some surface protein on stomach cancer cells. And then when it does that, then it's able to bring the T cell close to the stomach cell and work its magic, which T cells normally work on killing anything foreign they see in the body. So this is a little bit more detail. So here's the CAR T cell. So we can now use viruses to get into the CAR T cell and express this chimeric antigen receptor seen here. There's some target antigen or target surface protein on the tumor cell. So once the T cell engages that, the T cell's normal job in the human body is to kill bacteria, virus, foreign particles, and tumor cells. So in this case, then once the T cell's activated, when that receptor engages the tumor cell, it releases these proteins. Here it says granzyme that work on killing. It goes into the tumor cell and kills it. So we think this is also another very targeted, specific way to kill the tumor cells. And this is how the process works. So leukapheresis, so the patient comes in, we draw blood from the patient, we expand their T cells, and then we use viral vectors to put in the chimeric antigen receptor into the T cells. As you can see here, we expand them significantly, and then we put it back into the patient's arm. And what we call vein to vein time, so step 1 to step 5, taking the blood out to putting it back in, it takes anywhere from 2 to 5 weeks. And actually, this process is actually getting faster and faster. There are now 7-day vein to vein times for some of the CAR T cells. And the one CAR T cell that's of interest right now in clinical trials, and actually they're launching a phase 3 large global trial, is a CAR T for Claudin 18.2. So approximately anywhere from 45 to 75% stomach cancer patients will express Claudin 18.2. And if you look here on this slide, so normal stomach is seen on the left. So these are normal stomach cells. And Claudin 18.2 is the red squiggles you see here. And normally, Claudin 18.2 is expressed on normal cells, but you don't see it on the surface because they're expressed between the cells, as we can see here. But if you look on the right, when you have stomach cancer, the cells break apart. So all of a sudden, Claudin 18.2 is expressed, it can be seen by anything within the stomach area. So the clinical trial for Claudin 18.2, there is a response rate in phase 2 studies of 42%. That meant that the number of patients that come in, 42 show they're responding to some degree. But unfortunately, there are some adverse effects, and partially because we think some of the Claudin 18.2 is probably in the normal stomach is visible to the CAR T. So it's killing normal stomach cells, which is causing some of these side effects, which we're trying to get around. So a couple ways we're getting around this. One is to we have new targets that are really only specific for cancer cells. But the other is something called bispecific, meaning part of the CAR T binds to Claudin 18.2, but the other part binds to a second stomach cancer protein. So that means the T cell will only be engaged when you have it binding to both this and the Claudin 18.2 and something else. So that way it sort of removes the side effects that you would see by targeting these normal expressing Claudin 18.2 stomach cells. So this is some work that we've done in my lab with these bispecific, and actually we show no side effects on the mice and really effective killing of the stomach cancer cells that express Claudin 18.2 and another tumor protein called TGF-beta. And we are hopeful to get this into phase 1 trials by the end of 2025. So we're really excited about that. So the next class I wanted to talk about was something called radiopharmaceuticals. And the idea of radiopharmaceuticals, again, same thing, targeted treatment where you have a radioisotope, you have something linked to it, and then a targeting molecule that will bind to a protein. So you see this repeating theme of personalized therapies for specific proteins on a cancer cell. And so when you look closely, what is really exciting, I think, about radiopharmaceuticals is the idea that it can be used both as a diagnostic, which I'll explain in a minute, or as treatment option. So here's a radiopharmaceutical, there's some linker here, and a binding molecule. And so that will bind to something on the cancer cell. And in this case, so I talked a lot about Claudin 18.2 in CAR T and in ADCs, and those are a type of drug called antibodies. In this case, you don't really use an antibody, but you use something that will bind to Claudin 18.2 or some other cancer-specific protein. And once it binds, then it allows the same idea as the antibody drug conjugate. Instead of a chemotherapy that enters the cell, it ends up being a radioisotope, which does the same thing. It causes DNA damage and kills the cell, but it does it at a very specific to the tumor cell. The key to being very specific is the binding molecule that we would have here. So what I mentioned before about it being a diagnostic, Many of you might be familiar with this concept of FDG PET. So FDG is a glucose. It's a sugar that's taken up by growing cells. So a lot of times, if you look at this top row, when you're doing FDG PET, you do the scan to see where you have tumor cells growing. And I highlighted esophageal cancer here. But FDG PET is just a sugar that's taken up by a lot of actively growing areas. So as you can see here, the brain always takes it up, right? And the kidneys take it up, and there's some of the GI tract. But radiopharmaceuticals, you can use a very specific protein that's only specific to cancer cells. So FDG PET, non-specific, so it's everywhere, but you can still see the esophageal cancer here. But in the case of FAP, and that's something called fibroblast activating protein, the name is not, important, but what's important is that FAP has been shown to be a very specific tumor expressed protein. And it's not just stomach cancer, it seems to be expressed in many tumors. And as you can see here, you don't see any of the brain uptake. So we use this as diagnostic. So depending on which radioisotope you have linked to the FAP, you can either use it as imaging to show where the tumor is and if it's spread, or you can use it as a therapeutic option, meaning it's a different type of radioisotope that will get into the cells and kill the cells. In this case, this just lights up the cells. And we're excited about this. And this is actually in clinical trials in phase 2, I believe, trials now for a lot of solid tumors, including stomach cancer patients. So they get a diagnostic image. So they first get this FAP to see whether or not with this isotope, it's called gallium-68, to see where the tumor is. And then they get treatment. They get that same FAP with a radioisotope that will kill the tumor cells. So we think this is a really specific, and we're hoping low side effect treatment option. So no data yet from the phase 2. They're actively enrolling. And we are also generating this against Claudin 18.2 and some of the new stomach cancer proteins that I talked about we're discovering through experimental approaches. And so here's sort of an overview of the targeted radiopharmaceuticals in clinical development. So Claudin 18.2 is a big one. Lots of preclinical studies showing specificity, but again, that worry that perhaps Claudin 18.2 targeted radiopharmaceuticals will also affect normal cells. So we're a little worried about that. And then FAP, that was the imaging I just showed you. But we're also really excited about a bone-seeking peptide that's in preclinical development that we hope to get to phase 1 by the end of the year. And this is for bone metastases, which is not so common in gastric cancer, but probably in 5 to 10% of the patients. And this trial is going to be for all solid tumors that spread to the bone. And the preclinical data on this looks really exciting. So one, we can use a diagnostic to put this bone-seeking peptide into patients to see, do you have bone metastasis? And we can detect it earlier than current means. And then if you do, change the radioisotope to something that would kill the tumor cells that are present in the bone. So this is something I think pretty exciting. And then the last area I want to talk about is cancer vaccines. So I think, with COVID, we're all aware of vaccines and the flu vaccines. So we're familiar with this idea of vaccines as preventative, meaning you get injection of something related to the flu or COVID, like a dead version of the virus, and then you train the immune cells, right, to respond to this vaccine. And so that if you get exposed in the future, then your T cells will get activated and can kill, the infection before it happens. So now cancer vaccines is a therapeutic option. So it's the same concept where you inject a patient with a cancer vaccine and you train your T cells, your immune cells, to target any cells expressing, the vaccine. So I'll talk a little bit more about how we develop these vaccines. And they find the cancer cells, and then anything expressing these vaccine proteins gets killed by the T cells. So it's, again, getting your own T cells, similar to CAR T, to work against this. So how do we make cancer vaccines? There are a couple different ways. I'm going to talk about the approaches that Tori Coase is funding and supporting, and the groups working on this. And they're doing a personalized approach. So we take normal cells and a sample of your tumor cells and then do a lot of DNA sequencing to understand what the tumor is expressing versus what your normal cell is expressing. Because, of course, we only want to make a vaccine against the tumor cells. And then we're doing a personalized approach, meaning, every patient we get sequence, and then we do what we call neoantigen. That just means new proteins. So neoantigens are something that's going to only be expressed by the tumor cells. So we look at the whole list of those and we make them. So we can either make mRNA vaccines or a different type of vaccines called peptides, although we're leaning towards mRNA similar to COVID because that can be done very rapidly. And then we give them to the cancer patient, and and then we hope the immune system will be activated and kill the cancer cells. So right now we're in the neoantigen discovery phase on, number of patients to understand, are the neoantigens generated by stomach cancer cells, are they going to be enough to mount an immune, are they going to be strong enough to activate the T cells? So we're in that discovery preclinical phase now. But I did want to share some data from a pancreatic cancer trial. This is from Memorial Sloan Kettering, and this is for pancreatic cancer patients who had surgically resectable disease, meaning, they had local or locally advanced disease that were candidates for surgery. So after surgery, these were all personalized neoantigen, just like I described to you. And they got the vaccine. There's a whole delivery schedule for them, and they've been following these patients. And this paper was published, and this is by Vinod Balachandran at Memorial Sloan Kettering, at an 18-month follow-up. And so we haven't met the median time point, but it so far has been showing in this cohort of patients with local or locally advanced surgically resectable disease, it significantly extends the time until disease recurrence. So they're out at now at 30 months. As you can see, not 50% have not yet. RFS means recurrence-free survival, have not yet recurred. So the median time to recurrence in these patients historically is 6 to 12 months. So it appears to be passes. It's only 19 patients, so it's very early days. We're excited about this possibility and starting a trial for stomach cancer patients, which we think we can start a phase 1 trial in a personalized neoantigen within 13 months. So our goal is February, March of 2026 to have this trial open for stomach cancer patients, probably initially with local and locally advanced, and then as our technology and knowledge expands, for later stage disease. So that's it. It's a broad overview. I just want to thank to all of you patients for clinical being involved in clinical trials, to all the families, all the patient advocates for all your work on behalf of our patients. And with that, I'd be happy to take questions.
Thank you, Dr. Riem. Now we would like to open the floor up for questions. Please, we've got someone in the audience.
Oh, hi. Is there any way we can get a copy of your PowerPoint? I was trying to, furiously write.
Yeah, no,
I took a lot of notes.
Yes, I will say they have it, and they're welcome to send it. The only thing I didn't put, let me put all the references to where I got some. A lot of those cartoons are from different websites. I just realized they all came off somehow. So let me put those on, and I'll send a copy back, just so the people who drew those get the credit for drawing those. Some of them are my drawings, but a lot are just taken from other websites, I thought. But yeah, absolutely. Happy to send it all.
That would be great, because I want to be able to explain it to my my oncologist, because it seems as if you're more ahead than we are back Pacific, West, LA. Thank you. Sorry. And because I would love to educate my doctor, because I'm ready to go to you guys. Like, please, my PD-L1 pathways, yes, are positive, but my NTRKs are negative. But if I can get onto your clinical trials and dump my clinical trial and come onto you, so I can get rid of this, that would be great. So I just wanted to see how I can marry you with my oncologist to see if you guys can just talk and get me on that.
Absolutely. So the Test Your Biomarkers website, which I put the website link on there, this is No Stomach for Cancer that started this, got a lot of industry funding for this, but they have links to trials for all of these biomarkers. So, if you go to that website, which is on the slide, but I'll add some notes on the slides for you guys so you know where to go and how to find these trials. So all of the things I talked about, many of them are in clinical trial, early stage. So I don't know what, may not be the location near you, but definitely worth exploring and talking to your oncologist. And you can call the clinical trial lead investigator directly as well and talk to them about eligibility.
And that number is?
Well, it's going to be different per trial. So I'll give you the link where you can look up. So for example, if you wanted to do an FGFR trial or a KRAS trial, et cetera, like I could tell you each individual one. So I'd have to know a little bit more about your,
that would
but
be
I'll send
great.
you a couple of links. I'll put those on there about where you can find stomach cancer biomarker specific trials.
Thank you. I really appreciate it.
All right, question on what do you do if you see a marker and the person doesn't have it? Is that really like saying I shouldn't add gasoline to my bicycle because there's just no chance, but I might be able to add a tire from a wagon on a bicycle, that might work. Where do you sit as you look over all of these? Is that case by case? I don't have PD-1, ligand overexpressed or something like that. So does that mean immunotherapy is just stupid? Versus something like HER2, where my understanding is it is quite stupid to use it if you don't have that marker.
Yeah, so actually you're exactly right. So HER2, you wouldn't use it if you didn't have the marker. But PD-1, PD-L1, that's an interesting point because there's a lot of studies now that show PD-L1 negative still benefit. So there's a lot of data depending on your biomarkers. And this is why, cancer treatment is really personalized, right? So where you are, but now there's all these other, so maybe you don't have PD-L1, but might you have FGFR2 or KRAS or VEGFR2 or, there's a whole list. And so part of that is getting your, tumor sequence or tumor biopsy sequence, and then also having some slides available from the biopsies that you can have them stained at these clinical trials, which will test your eligibility. There's actually a lot more that I didn't talk. Nectin-4, TROP3. So there's a ton. I think that the Test Your Biomarkers website should have the whole list of all of the potential biomarkers, but I'm also happy to put together the list for this group and disseminate. Aki can disseminate it and link it to the trials. So the name of all these proteins that we know are in clinical trials now that are expressed by stomach cancer cells.
Awesome. We had one more up front.
Hi, thank you so much for your presentation. We are thankful to be at Columbia working with Dr. Yoon and Dr. Moy. And I wanted to ask, my husband didn't qualify for the mismatch repair PD-L1, HER2, and I think Claudin. So it was kind of like you're not a candidate to do the immunotherapy. But similar to what he said, is there something that he can do, or how do we find out which biomarkers he does have? It's probably in his reports. He was just diagnosed 5 weeks ago, starting treatment on Tuesday. So this is all fairly new to us. We just wanted to know what he might. And just listening to your presentation, it sounded like CAR might be a good one for him, but I have no idea what his biomarkers are. I just know what they are not.
I actually work very closely with him, and he really knows all the latest. So you could go into, I would, spend some time talking to Dr. Moy about potential other biomarkers, right, that he might be eligible for in terms of treatment. Is he surgically resectable? Will this be a surgical?
Initially it was all contained within the stomach, and he was going to have FLOT surgery and then FLOT, and then they found a tiny speck because Dr. Yoon is so diligent and he was doing the diagnostic laparoscopy, found a very small scar, tiny. It didn't show up on anything else, and because of that, now it's outside of the stomach. It was on the abdominal wall.
Okay. So I think Dr. Moy really is up on the latest, but you could make another appointment to talk to him specifically about other biomarkers and that you're interested in trials. He has a lot of trials open. Actually, he has one of the radiopharmaceutical trials open. And, interestingly, I like that what you said, finding that small spot. I think some of the radiopharmaceuticals will be more sensitive and will be able to really tell us if tumors have spread. So you're in really good hands, and happy to connect with you offline about specifics that we can talk about in detail.
Okay, great. Thank you.
Thank you, Dr. Ram. We really appreciate your expertise and all of your knowledge. We will now, we are so glad you're able to be with us today via Zoom. And now our next session, we're excited to share with you an interactive nutrition and cooking demonstration provided by Caitlin Binda. And Caitlin is a registered dietitian and board-certified specialist in oncology nutrition, who has been part of the Nova Scar Cancer Institute and Life with Cancer team since April of 2019. With a lifelong fascination for the relationship between food and behavior, she earned dual bachelor's degrees in psychology and nutrition dietetics in 2007. Caitlin went on to complete her master's degree in nutrition at Tufts University, while finishing her dietetic internship at Tufts Medical Center. Throughout her career, she has specialized in supporting the nutrition needs of individuals diagnosed with cancer across radiation, medical, and surgical oncology settings. Currently, Caitlin focuses on providing personalized nutrition care for patients with gastrointestinal cancers. Her expertise includes addressing the unique nutritional challenges faced by gastric cancer patients, offering practical strategies and optimize nutrition, manage side effects, and improve quality of life. Molly has been a practicing registered dietitian since 2010. Until moving to the DMV area in 2019, she primarily worked supporting complex nutritional needs of patients in a critical care setting. She shifted her focus to oncology when she began working with the Nova Scar Cancer and Peterson Life with Cancer in April of 2020. Molly is a board-certified specialist in oncology nutrition and nutrition support, and is thrilled to have discovered her passion for helping individuals navigate the nutritional challenges associated with cancer and cancer treatments. Welcome, Caitlin and Molly.
Okay, can everyone hear me? Awesome, wonderful. All right, well, thank you so much for having us. So I'm Caitlin, and this is my colleague Molly, and we're both very excited to be here with everyone today to share some information with you about practical strategies for helping manage gastric cancer throughout the journey. Oh, perfect. So just to get started, so both of us are in the Northern Virginia area, and I wanted to share a little bit of information about where we work. We work at the Nova Scar Cancer Center, which is a leading cancer center in the Northern Virginia area. And through this, we're able to offer advanced and personalized care through a multidisciplinary team. So one thing that Molly and I are very fortunate is that we get to work with our medical oncologists, our radiation oncologists, surgical oncologists, the nurses. We get to work really as a part of a very integrated team, which lets us become very kind of specialized in what we do. The other part of where we work is the Nova Peterson Life with Cancer, which is the image on the right, I guess. And this is a very unique program that provides free support and education and wellness programs to help individuals with cancer and their families and any loved ones connect with free services available across the entire hospital system. So what's also unique to Life with Cancer is that we see patients throughout the DMV area, whether or not they're being treated at our facility. So this includes access to nutrition services, but it also includes access to therapy, fitness programs, group support classes, so lots of different beneficial things to help support patients as they're going through cancer treatments. So I just wanted to get started. So why is nutrition important? I'm sure there's a lot of information that comes out about nutrition leading up to diagnosis and definitely after diagnosis and during treatment. But what we really know is that nutrition is very important because unintentional weight loss leads to a lot of adverse side effects. So we can see a decreased treatment tolerance where we're seeing more side effects, which can lead to delays in treatment. It can lead to changes in treatment plans because of that decreased treatment tolerance. It can lead to an impaired immune function where there's a higher infection risk, therefore malnutrition increasing that risk of infection or making it harder to fight infections or recover from illnesses. A loss of muscle mass, which is one of our primary focuses throughout the cancer journey, is trying to maintain that muscle mass or lean body mass. This can lead to reduced physical function, decreased strength, mobility issues, increased risk of falls, just decreases in overall functional ability and quality of life in general. It can also lead to delayed wound healing and surgical complications, and we'll talk a little bit more about that kind of as we get further into the PowerPoint. But one of the biggest things I think is most important is malnutrition, unintentional weight loss can really lead to a poor quality of life, causing more fatigue and more weakness and just preventing people from being able to go on and live life as they would otherwise prior to a cancer diagnosis. So at the time of diagnosis, up to 85% of individuals with gastric cancer report unintentional weight loss, and 60 to 85% of individuals meet criteria for malnutrition. When we look at malnutrition, there's a variety of different criteria that we use in order to diagnose malnutrition. Unintentional weight loss of a certain percentage over a certain period of time is one of the main factors, but other things that we look for are decreased oral intake, where somebody may be meeting less than 75% of their nutrition needs for greater than a month. We also look for physical signs of muscle wasting and fat loss. So it's not just based on weight loss, but it's really based on kind of a myriad of factors to really arrive at the diagnosis of malnutrition. But one thing we're trying to do, it's much easier to prevent malnutrition than it is to treat malnutrition. So that's always our primary goal, is trying to maintain nutritional status throughout the treatment journey. Okay, so on the flip side, so nutrition is also important. So what are the benefits? We talked about all the negatives, but why do we want to maintain nutritional status? So we know that maintaining or optimizing nutritional status throughout treatment can lead to improvements in strength and energy. It can lead to an enhanced treatment tolerance, improved immune function, preservation of lean body mass or muscle mass, improved treatment outcomes, again, somewhat related to better tolerance to treatment, ability to stay on a treatment longer or not have the dosage reduced because of poor tolerance to treatment, and again, an improved quality of life. So good nutrition really is not just about eating well, but it's really about maintaining strength, energy, and emotional well-being. So I talk with patients all the time that while the nutrients in food are very important, there's a lot of other things that come along with nutrition too that also are very, very important in just maintaining good mental health and good physical health overall. Okay, so today's objectives. So the first one, just very simple, understand the importance of nutrition throughout the gastric cancer journey. I'm assuming, everyone here having been touched by gastric cancer, everyone's probably had nutrition cross their mind at some point in time. So probably that's something that is already something that you're familiar with and understand how important it is to maintain nutrition going through treatment. Exploring strategies to manage symptoms and improve nutrient intake, that's a big one that we focus a lot on in our practice, is trying to ensure that we're managing side effects of treatment well. And addressing the psychological impacts of eating and living with gastric cancer. Again, there's a lot more layers to eating than just sitting down and eating a plate of food, but there's a lot of psychological impacts that has, especially when you've had surgery or you're going through treatment and you're having challenges with eating. And then finally, learning practical tips for managing long-term wellness following a gastric cancer diagnosis. So here, kind of the way that my mind works when I think about kind of giving presentations and talking with groups is kind of going through the stages, because it's definitely a journey, and everyone's journey looks a little bit different. Here I put stars next to before surgery and after surgery, knowing that everybody that comes in is not a surgical candidate, and that can change the journey a little bit, but I wanted to kind of walk through kind of longitudinally how we would think about nutrition going throughout the journey. So as I mentioned, our primary goal during active treatment meaning like chemotherapy, radiation therapy, is really to maintain weight and lean body mass, again, for all of the reasons that I mentioned before. The other thing we think about too is optimizing nutrient intake. And so I'll talk about this a little bit more in the next couple of slides, but when I think about optimization, that can look different for different people, because if one person is really struggling to eat just in general and they're struggling to maintain their weight, optimization for them is going to look different from somebody who is tolerating treatment beautifully and they have no side effects and they're not losing weight. So optimization is really an individualized factor, and that really just depends on how an individual is doing as they're going through treatment. But the thing that gets in the way of this, obviously it's a really great pie-in-the-sky goal, but the thing that gets in the way of this is obviously side effects from either the tumor itself or from treatment. So we refer to these as nutrition impact symptoms. So different things like anorexia or loss of appetite, where there's just no desire to eat. Nausea and vomiting, diarrhea, constipation, mucositis or mouth sores. Taste changes are a big one. Early satiety or feeling full very quickly after only a very small amount of food. Dry mouth, fatigue, and then dysphagia or difficulty with swallowing. So obviously these can provide challenges of achieving these goals, very simply straightforward. So over the next few slides, what I wanted to do is talk a little bit about how we manage some of these side effects. Before I get there, so as I mentioned, if someone's going through treatment and they really aren't having any of these symptoms, or they're having these symptoms but they're not impacting their ability to eat or drink, when we focus on nutrition, we focus on more of like a well-balanced diet with a primary focus on protein intake. Protein is the thing that is most important for maintaining our muscle mass, and getting protein in consistently throughout the day is really more beneficial at maintaining and building lean body mass than it is in getting like 80 grams in at one part of the day and then 10 grams spread out over the remainder of the day. So we're focusing on protein intake throughout the journey. And here I have a picture of different protein sources. One thing that's important to note is that animal proteins like meat, chicken, fish, dairy products, and eggs, it's a higher quality protein than our plant-based proteins like our beans, our nuts, our seeds, tofu. It doesn't mean that one is necessarily better than the other or you shouldn't eat plant-based proteins, but when you're eating well, you can have a little bit more variety from where you're getting your protein sources, versus if somebody's really struggling to eat, we might focus on more of those animal-based protein sources just in order to get a better absorption of that protein and utilization of it in the body. In addition to protein, when we don't have side effects, the other thing that we can focus on a little bit more is an increased intake of colorful fruits and vegetables. So this is where I think about the optimization piece. We know from the cancer prevention research that one of the most important things is really plant-based foods and a good variety of colorful fruits and vegetables. That's where a lot, when we think about, I have patients all the time that tell me they don't get enough greens. And I always say, green is important, but so are all of the other colors of the rainbow. And with those different colors, a lot of that is dictated by the phytonutrient profile or the antioxidant profile that's found within those fruits or vegetables. So when someone is eating well, the biggest secondary focus would be to try to make sure that we're getting a really good variety of colors of fruits and vegetables, really just trying to span the entire color spectrum as much as possible. The little equation that I have here at the bottom, I really like because I think it's very simple and a very easy way for really all of us to be eating. But protein plus some sort of colorful fruits and vegetables, every time that someone's eating, whether it's a meal, whether a snack, is really ideal just for diet optimization overall. Okay, so with the presence of nutrition impact symptoms, so when we're having nausea, vomiting, diarrhea, all of, a mix of these other side effects, the primary focus really becomes on adequate calorie and protein intake to minimize unintentional weight loss. If someone's not having side effects, they're going to have a much easier time maintaining their weight and maintaining their usual intake than if we are having these different side effects. So our goal really is to, one, try to enhance medical management of these side effects so that we're taking medications that are needed to prevent nausea or to manage diarrhea. But there's also diet restrictions that we can put in place, or kind of diet modifications that we can put in place to assist with symptom management. So really when I have somebody coming in that's starting on treatment, if we aren't having side effects, my biggest recommendation is keep eating as you are, focus on protein intake. But as soon as we have those side effects come in, that's where we kind of have to pivot and shift, even just for a period of time while those side effects are ongoing, and then we can return back to that regular diet after. Hydration, no matter what, is very important, but especially in the setting of any of these nutrition impact symptoms, it becomes even more important because a lot of them interfere with that desire to eat or ability to eat. You can make up for lost time with food. So if there is, a few days where you're not eating well because of treatment side effects, you can kind of make up for that on the tail end potentially. Hydration, you can't. If you go for a few days with not drinking enough, you're going to end up, in a poor position and, potentially, needing IV fluids, hospitalization, things that we try to avoid doing. So hydration is really, really key. So if there's days where side effects are really just very challenging to manage, hydration becomes that primary focus with nutrition kind of after it. Just in general, so within the next few slides, I'll go more into managing some of the specific side effects, but one thing that is a very common theme is small frequent meals. I always talk about scheduled small frequent meals, not waiting to feel hungry to eat, but trying to eat within an hour of waking up, and then every 2 to 3 hours from there on out. And if hunger cues are absent, doing things like setting timers or using commercial breaks or setting yourself up for success when it comes to eating. So putting things maybe nearby a chair where you're eating, or nearby a chair where you sit frequently, or if you walk to the bathroom and you're passing a little table, things that will set you up for success. The benefit of this scheduled small frequent meals, it helps with managing side effects of anorexia, early satiety, nausea, and GI symptoms, both of diarrhea and constipation. It also maximizes your overall intake. It gives you more chances to get nutrition in throughout the day. So if you're only eating 3 times a day and you're eating a small little portion, you've only got 3 shots to get nutrition in, versus if you're eating 6 times a day, you've got 6 opportunities to really get those calories in, to get that protein in, and to maximize what you're getting in overall. Including protein-rich foods with all intake. Again, we talked about that with the little equation, but it's even more important when we're struggling to eat, because if you're getting in, let's say 10 grams of protein 3 times a day, 30 grams is nowhere near what any adult needs. But if you're doing it 6 times a day, then that's a much better opportunity, and you're going to be meeting a much greater percentage of your overall nutrition needs. And then finally, oral nutrition supplements if needed. We talk about, the standard high-calorie, high-protein nutrition shakes that people either love or hate, but it's something that we think about them as supplementing what someone is able to do with their oral intake. So if you're struggling to meet your nutrition needs, or if there's periods, where someone has a really sore mouth and it's easier to get liquids in, we kind of shift to using those to supplement more during periods like that, and then shifting back to a regular diet when they're not needed as much. So that if needed is very dependent on each person, but also just on kind of what's going on as far as side effects. Okay, so the first one, anorexia or poor appetite. I believe that I already mentioned a fair amount of this. One thing that I didn't is behavior changes to help with enhancing appetite. So, if someone isn't hungry and they're not wanting to eat, being set up for success is going to be a lot better than to have to struggle to think about what to eat. Eating in a low-stress environment or with cheerful surroundings can really enhance the amount that someone is able to consume. Also, sometimes mindless eating. We talk in the world of just like general health and nutrition, people talk about mindful eating, but if we're struggling to eat, we don't want to be focusing on every bite that we're taking on the plate. We want to be watching TV, listening to music, talking with family and friends, doing something to distract us from the chore of eating, the food in front of us. So that mindless eating can be very effective at trying to get a little bit more in. One thing that I focus on a lot with my patients is positive reinforcement. We're so quick to beat ourselves up over what we don't do enough of. So if you were to put a normal amount of food on your plate and you only eat 25% of it, it's human nature to look at it and say, oh gosh, I didn't do enough. I should have done better. But what we want to do is try to shift that to being more of the positive reinforcement of saying, look what I was able to do. I didn't have to eat anything, but look, I was able to get this done, and then coming back to it, 2 hours later, an hour later, whatever time that it is, and really just trying to be positive about it overall, because that mindset can play such a big role in our ability to consume nutrition. I put on here appetite stimulants if appropriate. We definitely use appetite stimulants in our practice. They come with more side effects, just as any other medication does. And they're not a very rapid onset, and they aren't always even guaranteed to work. But it's something where I try to get patients to focus on behavior change first and really trying to get in a good routine of eating again. Because when you've lost that appetite, you kind of lost your habit of eating. And at the end of the day, eating is a habit. We just don't think about it as a habit very often, because when our stomach's growling, it's reminding us. But when your stomach's not growling and you're not feeling hungry, you kind of have to keep that habit going, even if it's only small amounts. The more often that we can kind of retain that, the easier that it is to build back over time. Early satiety or early fullness. Again, a lot of the same, the scheduled small meals every 2 to 3 hours, or even more often if someone's only able to consume a very small amount at a time. When I think of a small meal, I normally think about like of a half a cup to a cup of food or liquid. So if someone's only taking a couple of bites, trying to get eating, really just constant grazing throughout the day, every couple of hours, getting a few bites in or a few sips in of whatever it is, and then trying to maximize the calorie and protein content of those kind of small portions as much as possible. And when Molly does our food demo with the smoothie, she's going to talk some more about some of those strategies of how we really work to maximize calorie and protein intake, not to get someone to eat more food, but to kind of pack more nutrient density into the small portion that they're able to consume. Liquid calories can especially be good for early satiety because we don't feel fullness the same way we do with liquids as we do with solid foods. So if someone's feeling very, very full, sometimes alternating between solids and liquids can be very helpful, or relying more on those liquid calories just if it's an easier way to get nutrition in for that period of time. One other key thing is to avoid drinking large amounts of liquids with meals because you have precious real estate, kind of as you're going through treatment. And if you're not feeling very hungry, if you're taking up the room that's in your stomach with liquids, it's not going to give you the same kind of amount of food that you would be able to get in otherwise. Nausea, small frequent meals, again, is something that we recommend. And a lot of this is really to avoid an empty stomach. We know that there's gastric acid that's being produced, and if someone's prone to nausea during their treatments, it's something that the empty stomach with that gastric acid, it can worsen nausea. So trying to keep something in the stomach, something going through the GI tract to avoid the risk of nausea is very beneficial. Also, bland, dry foods. We think about the old brat diet, bananas, rice, applesauce, and toast. It doesn't have to be quite that limited, but keeping things very dry, very starchy, very bland can be helpful in managing nausea. A lot of times nausea tends to be triggered by smells, and so if that's the case for you, I'm trying to gravitate more towards like cold or room temperature foods. And if it's not you that's preparing foods, trying to avoid the area where the food is being prepared so that you're not kind of coming in with a preset kind of expectation of, okay, well, I'm already feeling nauseous from this, and just you kind of come into it more fresh. Ginger is also fantastic. Ginger comes in many, many forms now. So ginger can be a great analog to nausea medications. Or acupressure, which I know there's acupuncture out there, and we do acupuncture also at our center for management of nausea. But is anyone familiar with like the C-bands or the acupressure points? Yeah, so that's something where it can be, I have people that think, where Molly's demonstrating, kind of on the inner part and the tendon, the little ball just sits between the two tendons of the wrist, about 2 to 3 fingers up. You can also do manual acupressure. It doesn't have to necessarily be a C-band, but you can do manual acupressure, which is just as effective as the acupressure bands. But some people think they work great. Some people don't think that they work at all. But what I like about them is they're $8 typically. So it's not a very expensive intervention to try, and if they help, then it's a fantastic thing to add in. Vomiting. There's not much we can do. If you're having vomiting, there's not much we can do from a nutritional standpoint because food's not going to stay down. The biggest focus becomes on hydration, especially during that time. Sips of clear liquids, ice chips, popsicles, Italian ice, things where you can just get in small volumes of liquid over the course of that period of time. Electrolyte replacement beverages like Gatorade, Liquid IV, Drip Drop, Pedialyte. There's so many different ones that are available on the market right now, but that's a really good time to use them because if you're having any sort of GI losses, you're losing electrolytes with it. So that's a time where it can be really beneficial to do electrolyte replacement drinks over water because they're going to help with replenishing those electrolytes.
And you're getting some calories from that too.
Yeah, and you're getting calories from that too. I don't know if you could hear Molly. Once liquids are staying down, that's a good time to transition to very bland foods, kind of that brat diet. There's a couple of other things that are listed up there as well, but that's kind of the first step after liquids, once vomiting has been managed and controlled. Diarrhea. So the biggest thing with diarrhea that we focus on is a low-fiber diet in order to reduce the amount of waste that moves through the GI tract. So we don't digest fiber. Fiber is found in our plant foods, our fruits, vegetables, beans, whole grains, nuts, seeds, and our GI tract does not digest it. And so if someone's having diarrhea, if we're giving them more fiber, we're making more diarrhea, which is not what most people want to have. We want to have less diarrhea. So we try to really, really pull back on fiber intake. And that does lead to a period of time where all of these really great nutrient-dense foods that we talked about before kind of go away. But for a period of time, it's something where the risk of nutritional deficiency is not really elevated above and beyond kind of what we would normally have. Soluble fiber is the type of fiber that acts more like a sponge, and it absorbs liquid from the GI tract. And insoluble fiber is more of the roughage, and that makes more kind of volume and more bulk in stool moving through the GI tract. So if someone's having diarrhea, soluble fiber can be really, really beneficial to help with absorbing some of that liquid. And that's in things like applesauce, very ripe bananas, like the inside of potatoes, really just very good at absorbing that liquid. Small frequent meals are also beneficial just because there's not as much waste moving through the GI tract at a time. It's not a whole, huge amount of food for your body to digest. Hydration is, again, important for the same reason it was with vomiting, because if you're having GI losses, we need to make sure we're replacing fluids. And a good general rule of thumb is that for every episode of diarrhea, to try to replace it with 1 cup of liquid after that episode of diarrhea. Room temperature liquids may be better tolerated. Warm liquids can kind of speed up how quickly things move through the GI tract. So room temperature liquids may be better tolerated if in the setting of diarrhea. Again, electrolyte replacement beverages are very beneficial for the same reason they were with nausea and vomiting. There is the possibility of a temporary lactose intolerance that can develop with chronic diarrhea or diarrhea for more than a few days. And that's just because the GI tract doesn't really have time to kind of repopulate the lactase, which is the enzyme that breaks down the milk sugar. So it's something that if you're having diarrhea, you don't necessarily have to avoid dairy products. They're a great source of protein, calcium, vitamin D, other things that are very beneficial. But if you're noticing that you have a glass of milk or you have a yogurt and you have more diarrhea, then it's a good idea to switch to a lactose-free version or take like a Lactaid capsule, which will help to break down that lactose that's in the dairy product. Sugar alcohols are something that we do not digest, and so sugar alcohols are very well known to be causes of diarrhea. So if you're having any diarrhea, trying to make sure that you're not consuming more of these, which could be worsening diarrhea. And then finally, foods with pectin. Pectin is it's a good source of soluble fiber, but it also helps to absorb the liquid from the stools. So applesauce and ripe bananas, or there's products that have banana flakes. Banatrol Plus is one of them that we use fairly regularly that can help with slowing diarrhea without slowing the actual motility of the GI tract. So what works for one person isn't necessarily going to work for everybody. So with any of the GI symptoms, it's kind of like trial and error, really at any point throughout treatment. And one thing that can be really helpful is like a food and symptom log where you're writing down what you've eaten, did you have any sort of side effects? And that can kind of help to guide more for you individually with what you may need to avoid or include more of in your diet to help with managing symptoms. Constipation, we treat a little bit differently than we do outside of the oncology world. The biggest thing for me with constipation is we have to first evaluate what's causing it. We know that either because of medications, Zofran, pain medications, very well known to cause constipation. Diagnosis, depending on where a person's tumor is, that if it's lower GI, that can definitely impact how often they're going to the bathroom. Lack of food or fluid intake overall. If there's not much moving through the GI tract, things are going to slow down and they're not going to be moving regularly, or decreased physical activity. So the medications, the diagnosis, we can't do anything with those from a nutritional standpoint, but we can really try to encourage good regular food and fluid intake and regular movement and physical activity. And with physical activity, I tell people I don't expect them to be out training for a marathon, but just trying to go and, just like with small frequent meals, like small frequent intervals of activity can be very effective at getting your GI tract moving, can also help with just increasing appetite as well, and the benefit of maintaining lean body mass. So lots of benefits of moving as much as you realistically can going through any piece of treatment. That's what I mentioned in that last point, so. Taste changes, I think, are one of the most challenging side effects to manage because you've got nausea, we can give you medication. You have diarrhea, we can give you medication. Taste changes, we really don't have anything. And we could all be getting the exact same treatments and have a totally different perception of how things taste. And that makes it really, really hard. So very, very individualized. What I try to get patients to do is try to identify if there's foods that have a certain taste, if things are just tasting off, if they're kind of muted or bland, if there's no taste at all, if they're metallic, if they're super salty, super sweet, because that can guide a lot of what we do nutritionally for helping to try to alleviate some of those taste changes. One of the biggest things that is good to do in general, but especially for taste changes, are baking soda and salt rinses. They really just help to clear the oral cavity. And if it's something for a taste that we're trying to do to manage taste changes, if you do it before eating, it can cleanse the palate and make sure that there's not lingering flavors that are in the mouth that may be influencing how things taste. Also good to do afterwards for that same reason of just cleansing the palate, and can also help with reducing the risk of mucositis as well. Taste changes, it's a lot of experimentation. So trying to see, if there's different seasonings or flavors that maybe make things taste better or taste worse. So I really try to get people to experiment. If there is something that has always worked, trying something different to see if we can get something else going that we'll find some success with. Mucositis or mouth sores, the biggest thing with this is just finding foods that don't need to spend a lot of time in your mouth. So if you have mouth sores, especially on both sides of your mouth or in the back of your throat, the less time that things can spend in your mouth and kind of in that process of chewing and kind of swallowing, the better. So soft and moist foods are the first thing that we go to, or if we really need to move to more of a full liquid diet where things just need to be consumed through a straw where we can divert where the liquid is going, then that is where we kind of move to if necessary. Liquid calories, again, can be very helpful. And again, I mentioned drinking through a straw if necessary. And then the last one, fatigue. Fatigue is another challenging one because we know it's going to come along kind of with various parts of treatment and really throughout treatment and can worsen oftentimes as treatment goes on. Scheduled meals and snacks is, again, something that's important. Trying not to nap through scheduled times to eat is one thing I focus on a lot. It's really hard unless you have a feeding tube or unless you're on IV nutrition. It's really, really hard to eat while you're sleeping. And so, I tell people rest when you feel like you need to. But if you're resting 6 hours during the day and you were trying to be really diligent and eat every 2 to 3 hours, you've potentially missed 2 or 3 opportunities to get nutrition in. So trying to rest when you need to, but trying to not let it interfere with your eating schedule and with just kind of your ability to stay up and moving can be very helpful in managing fatigue. Ready to eat and easy to prepare meals are really, really key. So again, setting yourself up for success. So whether it's getting food from family and friends or meal delivery services or freezing stuff on days where you feel better that you make more food and then you freeze it, it really just depends on kind of what different resources are available to you, but trying to set yourself up for success where you're not spending a lot of time cooking or you're not spending a lot of time eating. Also, a piece of steak that's going to have to be chewed a lot is going to make fatigue worse rather than a yogurt that's going to go down pretty easily. So trying to be smart about what you're eating as well. And the biggest thing that we can do for managing fatigue is to stay active. So our body can get out of a routine and can become very used to just sitting very quickly. So trying to stay active can help with managing fatigue and can also help, obviously, with maintaining lean body mass, which is our goal at the end of the day. And before we get into the smoothie, I believe that's the one after this, I just wanted to touch, after this we're going to go in and talk a little bit more about before surgery and after surgery, but I wanted to touch on living with metastatic gastric cancer or living with a recurrence, because obviously surgery has either been done and we've kind of had a recurrence of disease, or surgery is not an option. And I wanted to touch on this because symptom management really becomes the priority. We're focusing still on trying to maintain weight, trying to maintain lean body mass, but the goal is really managing those symptoms to enhance quality of life. So really working closely with the treatment team in order to optimize symptom management, whether there's palliative care providers that work at your institutions, that's a great person to have on board to help with managing symptoms just to enhance and improve quality of life overall. Okay, and with that, I'm going to turn it over to Molly, who is going to do our cooking demo for the mango pineapple smoothie.
Hi, everyone. So we're making a smoothie. You've heard liquid calories come up many times today. It can be helpful if you have a poor appetite. It just takes up less real estate, like Caitlin said, in your stomach. If you get full really quickly, those liquid calories, we can really concentrate the calories and the protein versus sitting down to a daunting full meal of solid food. So smoothies are a fantastic opportunity to really pack in the nutrients, calories, protein. Today we're going to be adding some fruits. There's also opportunities for vegetables. They're so versatile that I really enjoy keeping my blender on the counter because I can make a quick breakfast for myself. And when you're struggling to eat, these can be really helpful. And also things like those taste changes or mucositis, the mouth sores that you have in your mouth, your tongue, back of your throat. If you're having any trouble swallowing, liquid calories can be the way to go. Of course, those commercial shakes can be great and helpful. They're also really pricey. So if we can make something at home, let's do it. So the recipes that we're using today are going to be featured in the Nutrition Guide for Stomach Cancer. That's going to be coming out on the Hope for Stomach Cancer website. Should be coming out really soon. So keep your eye out for that. And I believe that how are they able to access the book once it is available?
It should be posted on the website, I believe. So it's been a few-year labor of love in getting it out, but hopefully soon.
Awesome. All right, so today we're making a mango pineapple smoothie. The recipe that you see up here is featuring skim milk and non-fat Greek yogurt, and that's great. If we're just like, hey, I want to get some protein in the morning, I want to up my fruits and vegetable intake, that's a great way to make it without having too many calories, but oftentimes we're looking for opportunities for calories. So for today, bought some whole milk instead of skim milk, and then also a full-fat Greek yogurt. So that's an easy way to up the calories, is switching to full-fat dairy when you're using dairy. All right, so for this particular recipe, and this recipe, by the way, makes 2 servings, so you can save some in the fridge or the freezer for later. We're going to use 1 cup of frozen pineapple. You're not a pineapple girl or man? No problem. I am a pineapple girl. I happen to like it a lot. We could put some berries in here. You could put a frozen banana, which this recipe does use a banana, but that sweetness from the pineapple, you're going to want to find something that adds a little bit more. And so maybe if you're not a pineapple fan or maybe you have an allergy, you can use berries. And then maybe we're adding also a teaspoon of maple syrup or a teaspoon of honey, regular sugar, just to compensate that sweetness. All right. We're also going to use a cup of frozen mango. We could also add some veggies in here. A veggie that I think goes really well in most smoothies, blends really well, is spinach. Just putting a couple handfuls of spinach in there. All right. And then we've got 1/2 cup of milk. And again, I'm going for the full-fat dairy to boost the calories. Some other ways that we can boost the calories: nuts and nut butters. Peanut butter and almond butter, sunflower butter if you've got allergies. We can add some avocado, 1/2 an avocado. We could even use ice cream. Sometimes your dietitian is going to tell you, I want you to add more ice cream to your diet, just because we're trying to get those calories up. All right. And then we have 1/2 cup of vanilla Greek yogurt. Why Greek yogurt? Because Greek yogurt has a higher protein content. What are some other ways that we can add protein to this? Well, if we've added some nut butters to it, that's giving us healthy fats, it's giving us a little extra fiber, and it's giving us protein, so that's one way. We can use protein powders or dry milk powder also. Some good unflavored protein powders that are easy to find, and Caitlin turned me on to this one, is IsoPure, because you can get that one at Target. You can get it at Walmart also. But so many of the protein powders have a flavor to it, and that can be a little bit tricky to find. Just plain unflavored, that will go in a multitude of things, not just sweet preparations, but like I'm trying to add protein powders to my soup or my mashed potatoes. Those unflavored ones are harder to find. So IsoPure is a good one. Ungery is a great product. I think I found another one the other day at Walmart. I think it's Walmart brand. It's like Nutra Score? That doesn't make any sense, but that's what keeps popping into my head. All right. Good. So this is just a 5-ingredient smoothie. We've got our frozen mango, frozen pineapple, our whole milk. You can do skim milk if we don't need those extra calories. Half a cup of vanilla Greek yogurt, and a banana. I think this is going to be plenty sweet. So again, if we're adding more calories, we can add some avocado, we can add some ice cream, we can add a tablespoon or 2 of heavy cream, we can add some nut butters, which is also going to give us some protein. You can also add a couple teaspoons of any kind of sweetener that you like. Things that have fat in it are going to add even more calories, but sweeteners, maybe avocado isn't your jam, then let's add a tablespoon or 2 of honey or maple syrup. Okay. It's going to be loud. 1, 2, 3. After this, we're going to have a few samples available. If you're interested, you can come up to the front during the break, and I'll have some samples. Let me just check the consistency real quick. Like I said, they're versatile. So maybe the Greek yogurt that you bought is a little bit thicker than others, or maybe you went over just a little bit, like I suspect I did with the pineapple, and so it's a little thicker than you like. Just add a little bit of milk to thin it out. One more time. Sorry for the noise. That's better. All right. I'm sure this is going to be delicious. We'll give it a try at the end.
So another thing to think with thinning it out, I know a lot of times I'll have patients that thin out soups because maybe it makes it easier to go down and digest. Thinning it out with water is going to thin it out, but thinning it out with like milk or thinning it out with like orange juice, like for a smoothie, not like a soup, but is going to help add calories too. So because when you're thinning it out, you're decreasing the caloric density. And so when we're doing it with something like water, we're really kind of losing some of that volume that's providing us with calories. So finding things that have calories in it to thin things out can be really beneficial to still get that good calorie content.
That's a really good point. In fact, instead of using milk, if we're really needing to pack in those calories, we're struggling to get any in, using those nutrition shakes, we can fortify those nutrition shakes into something like this to really, really boost the calorie content and protein. Yeah.
Awesome. Okay. So now we're going to move into the surgery piece. So preparing for nutrition with surgery, I like to think of surgery as the marathon. So I put my little graphic up here of people running to the finish line. But really preparation is key. So if somebody is starting on treatment, we know that they're getting, perioperative chemotherapy. We start talking about preparing for surgery day 1 because we know that the better optimized and the better your nutrition is going into surgery, the easier that it's going to be for recovery from surgery and the better that surgical outcomes are going to be. So overall, good nutrition really helps to support healing. It helps to reduce complications, which can include post-op infections, post-op nausea and vomiting, and improve recovery and improve recovery time overall. So when we're talking about surgery, the biggest thing we're still focusing on is that weight maintenance. If somebody's struggling to maintain their weight, so coming out of the first few rounds of chemo, we're still just trying to focus on that weight maintenance. So trying to add in the calories, trying to make sure we're getting enough protein, just to support that basic level of nutrition in the beginning. Optimizing protein intake is very important. Generally speaking, it depends on weight, and when we talk about calorie and protein needs, it's truly an estimation. We have no simple way to know exactly what each one of us need on a daily basis as far as calories and protein go in a clinical setting. In like a research lab, we can do a better job with that, but that's not where we live our lives, is in a research lab. Hopefully not, at least. So optimizing protein intake, we generally look at like 1.2 to 1.5 grams of protein per kilogram. And so I try to get, and this is also the amount that we're generally looking at going through treatment also, but it's something where usually just having an increased focus on protein intake, if you're eating well and doing things like using Greek yogurt instead of regular yogurt, helps to usually get that extra boost of protein that we're looking for. I tell people that we don't need to go to Subway and like double size our meat portion or whatever else they offer. It's really just about kind of incrementally increasing it strategically at several instances throughout the day. That tends to be enough to kind of get us up to those increased protein needs. Exercise, again, is very, very important. And we used to talk more about rehabilitation. You know, you have surgery and maybe somebody goes to rehab to get physical therapy and occupational therapy to help them recover. But now there's a lot of focus on prehabilitation, so rehab before surgery. And what that really looks like is just training your body to really be optimized to go to surgery. Your body doesn't know good trauma from bad trauma. Surgery is trauma to your body, so it doesn't know that from a car accident. So what happens is during the surgical process, there's a whole slew of hormonal kind of cascade of events that happen that can lead to more inflammation in your body, can lead to more of like an inflammatory response overall. So kind of trying to minimize that as much as we can going into surgery is where we want to focus, because that is something where it can just make recovery easier and really reduce complications overall. Carbohydrate loading is something that surgeons will use sometimes as a part of an enhanced recovery after surgery protocol. This is something that tends to be very surgeon specific. It's more standard now than it was a few years ago, but that's something that sometimes like an Ensure pre-surgery is a specialized carbohydrate drink that is consumed. We do 4 hours before surgery. The general recommendation is 2 hours, but our anesthesiologists were only willing to go to 4 hours, so we do 4 hours. And then sometimes also the night before, so that it's trying to build up that carbohydrate, kind of like you're carb loading for a race. But what that does is that can kind of minimize that inflammatory response when you're actually in the process of surgery. The enhanced recovery after surgery protocol, nutrition is one tiny little piece of the overall protocol, but it's something that after surgery too, they talk about trying to bring back solid foods more quickly, because we know that that's more helpful with GI function return rather than keeping somebody NPO or unclear liquids where there's really not much for the GI tract to work with. Okay, so I am not a surgeon, and I'm not here to tell you about all these different types of surgery, but what I really wanted to focus on is that there's a lot of different types of surgery for gastric cancer. And kind of depending on the surgery that is recommended, that can dictate a lot of the nutrition side effects or the nutrition complications that can occur post-surgery. So obviously the first ones are partial gastrectomies, and the total gastrectomy is the third one. Okay, so nutrition after surgery. So we talked about malnutrition as being common at diagnosis, but we also know that malnutrition is one of the most common post-op complications of either a subtotal or total gastrectomy. Weight loss of up to 13% in 6 months for a partial gastrectomy has been seen, and up to 17% in 6 months for a total gastrectomy. I talked about kind of the percentages of weight loss over time that we use to diagnose malnutrition. In a 6-month period, we're looking at anything above 10% as being a severe weight loss. So partial or total, both of those are meeting that criteria. So percentage-wise, it doesn't mean a lot, so I like to kind of translate it into people terms of like pounds. And so if we look for like a 150-pound person, for a partial gastrectomy or a distal gastrectomy, if they're starting out at 150 pounds, they're dropping to 130 pounds. That's a pretty big weight loss. And for a total gastrectomy, dropping down even further to 125 pounds. So it's something where definitely, we're trying to minimize that weight loss as much as we can. Really, again, just to enhance outcomes and quality of life overall in recovery. So generally after surgery, after the diet's been advanced, we're typically on a post-gastrectomy diet, which again includes our favorite things, small frequent meals. Eating slowly and chewing foods well is incredibly important, whether someone's had a partial gastrectomy or a total gastrectomy. Digestion starts with chewing in the mouth, so if we're kind of inhaling our foods, we're not doing a lot of that work up front that's really gonna make it easier to digest those foods. So chewing foods well, also to help with them just going down smoothly. and eating slowly, because satiety or fullness cues can really be messed up after surgery, especially after a total gastrectomy. And so trying to really eat slowly. And this becomes even more important, I think, as people get further out from surgery and appetite starts coming back, kind of you start resuming your normal life. And, you go and you look at, a plate of food, and you sit down for Thanksgiving dinner and there's this big plate of food and you're like, okay, I'm gonna eat like I did last year, and your body just isn't set up for that anymore. So I think that's one of the most challenging things kind of long term, is kind of relearning how much you can eat and what that amount is, kind of where you haven't eaten too much. Because what my patients tell me is that, there's a very fine line, is like, okay, this is enough, but then too much, it pushes you overboard. Avoiding gas-forming foods, broccoli, cauliflower, cabbage, a lot of those, again, really nutrient-dense fruits and vegetables, is important, just because that can cause more GI distress. High protein, again, very important. So I think our common themes of today are probably small, frequent meals and high protein. And then watching fiber intake. And a lot of that initially is really just because, again, we're gonna put more waste moving through the GI tract. And if you've just had a major GI surgery, we don't need more moving through there than what we want. So really just watching fiber intake. And it's something that can be added back in eventually based on individual tolerance. But initially, we really kind of push pause on it to allow the body to heal properly after surgery. These are some common post-gastrectomy complications. And again, total gastrectomy, the risk of a lot of these is higher than it is with a partial gastrectomy. But I put several up here, but the one I really wanted to focus on is dumping syndrome. A lot of these other ones are things that I've seen maybe fat malabsorption in my career after gastrectomy a handful of times, but a lot of the others I really haven't seen, and whether that's just because of how we're set up for follow-up, I'm not really sure, but dumping syndrome is where we tend to focus on kind of educating patients initially, so that after surgery they kind of know what foods to look for that can trigger dumping syndrome. So dumping syndrome occurs in about 20 to 50% of patients after surgery. So that's a really high percentage. And what happens is when food moves too quickly from the stomach into the small intestine, or if the stomach's missing, just into the small intestine after that reconnection, the body tries to dilute it. And so what it does is it tries to kind of rush fluid into the GI tract, and that can lead to a lot of different side effects, one of them being diarrhea shortly after eating. So this usually occurs after eating large amounts of sweets, such as sugar, honey, syrup, regular soda, fruit juices, and desserts and pastries. And I put a snow cone up there because I had a patient, he was an esophageal patient, but we also see this with esophagectomies. And he had told me, he was like, Caitlin, he's like, I had a really bad episode of dumping. And I was like, okay, what did you eat? And he's like, I drank the juice at the bottom of a snow cone. So that is my example now when I talk about dumping syndrome, because I was like, that'll do it to you. Like, that definitely will. So, so snow cone juice, good for calories, not good for dumping syndrome after any sort of gastric surgery. So. There's early dumping syndrome and there's late dumping syndrome. So early dumping syndrome, we're typically seeing symptoms 30 to 60 minutes after eating. These are symptoms like dizziness, sweating, feeling like your heart's racing, feeling very bloated, nausea, and again, diarrhea, like I mentioned. And to treat early dumping syndrome, the main thing that we want to do is try to sit upright in a chair or lie with the head of the bed at a 30-degree incline to slow how quickly things are moving through the GI tract. So we're trying to work against gravity. Right now, gravity's working in my favor up here. So if I'm horizontal, things are not going to move as quickly just because we've altered kind of the central point of gravity. Late symptoms are typically 2 to 3 hours after eating, and a lot of these are more related to the blood sugar. So feelings of weakness, feelings of hunger, again, feeling like your heart rate's fast, feeling kind of clammy. Those can be all symptoms of late dumping syndrome, and they can be associated with a low blood sugar when that does come. So if someone's having symptoms of late dumping syndrome, trying to have somebody eat or drink as soon as possible to correct the low blood sugar, and typically something that's a soft textured food or fluid that has carbohydrate and protein to slow kind of the absorption. If we're gonna just replace it with this orange juice over here, we're not going to help. We're going to see more of those early dumping syndrome symptoms. So something that's going to kind of provide carbohydrate and protein to ease and slow the digestion through the GI tract is going to be more beneficial for bringing the blood sugar up. The primary goal of dumping syndrome, though, is to prevent it. So treating it is one thing, but really we want to try to prevent it from happening. So again, limiting foods high in concentrated sugars like the snow cone juice. Avoiding fried and greasy foods can also sometimes be beneficial. Eating protein-rich foods and complex carbohydrates, that soluble fiber that we talked about before that acts like a sponge, that's going to slow how quickly things move through the GI tract, so it can be very beneficial for that reason also. Drinking liquids 30 minutes before or after meals, but not during meals, just to minimize the amount of fluid that's going through the GI tract at the same time as food. Again, our favorite small frequent meals, keeping portions small, and then eating slowly and chewing food into very small pieces or until fully liquefied. So really just trying to, I mean, the biggest one that I see and we focus on is limiting the concentrated sugars, but these other tips can help as well. Okay, so after surgery and kind of moving forward, so I wanted to talk a little bit about post-surgical nutrient considerations. And this is really taking into account, if you've lost a portion of your stomach or your entire stomach, there's a lot of nutrient absorption that goes on all throughout our GI tract, including in our stomach. So the biggest one that we want to monitor for after either a partial gastrectomy or a total gastrectomy is really anemia. And anemia can come in because of 3 different nutrients: iron, vitamin B12, and folate. Iron is the most common one that we see after any sort of gastric surgery, and this is related to a lack of absorption from the decreased gastric acid secretion for like a partial gastrectomy, decreased intrinsic factor production, or complete bypass of the duodenum. So it's something that we can see iron deficiency anemia very, very regularly, and again, that is the most common one. Vitamin B12 is another one that we can see, and this is because of loss of gastric acid and intrinsic factor, again, which the intrinsic factor is just, it's necessary for the absorption of the vitamin B12 in order to help with getting it into our body. And then the folate would be due to malabsorption. You can also see increased risk of metabolic bone disease, and so that can be caused by decreased intake of calcium, malabsorption of calcium due to reconstruction of the duodenum, or rapid transit time. If somebody is supplementing with calcium, one thing that's important to note is that calcium citrate is the form that's preferred over carbonate, because calcium citrate does not require stomach acid for absorption. So if your acid is reduced or missing entirely, that citrate is really going to be the one you want to choose because it's going to be absorbed better. Another thing to note that's important with calcium supplements is that they should be taken at least 2 hours apart from iron supplements because they compete for absorption in the GI tract. So if you're taking them at the same time, you're not going to get the full benefit of either of them. The other with metabolic bone disease is vitamin D. This can lead to a calcium deficiency. It's something where vitamin D is not abundant in our food supply. It's fortified in a lot of dairy products. Really the only other food sources that there's a significant amount in would be like in sardines or any other canned fish where you're eating some of the soft bones. It's not something that a lot of us eat on a regular basis, so there's really not a lot of vitamin D coming in from our diet. Our main source of vitamin D comes from sunlight and exposure outside to the sun, but it's something where if our vitamin D level is low, it can make a calcium deficiency worse. I didn't include on here any sort of recommendations for how much to supplement because it's something that's really an individual conversation with your physician, but routine lab monitoring is very important, and the ones that we'd recommend would be ferritin, which looks at that's your storage form of iron, so that's going to look at kind of your long-term iron stores and how much you have. Vitamin B12, the red blood cell folate is the form of folate that's better able to actually detect a true folate deficiency. And then the vitamin D, the 25 hydroxy vitamin D level. And then for monitoring bone density, DEXA scans can be really, really beneficial in looking just at how bone density changes over time. So it's not something that we do regularly in our practice, but it's something that it's definitely recommended to do, just especially depending on the age at which you're diagnosed. If you're young at the time of diagnosis, there's a lot more kind of bone mineralization and kind of life of your bones that we need to watch for in order to make sure they're staying strong moving forward. There are other at-risk nutrients just based on the surgery site: zinc, copper, thiamine, the fat-soluble vitamins, really as a function of fat malabsorption. And they're ones that we look out for. We don't routinely test for them, but we're kind of watching for symptoms. So you can also see anemia sometimes related to copper, or can kind of you don't have to develop copper anemia, but you can see changes like in your red blood cell count related to it. So it's something where it's just important to kind of be aware of them and just have conversations with your physician. Depending on time of surgery, usually that first year after or the first few years after, the surgeon might be the one monitoring these labs, but at some point it generally transitions to your primary care physician. So it's important that someone is just routinely monitoring these labs and that if any deficiencies are found, that they're being acted on so that nutritionally we're not facing these complications. Okay. So the last piece that I have is talking about survivorship. And I don't like the term survivorship because technically, from the time of diagnosis, you're surviving this diagnosis, you're surviving this disease. But it's the general term that we use, and so I didn't really have a better one to put up here right now. But when we kind of recover from surgery, diet's heading back to normal, what do we do with nutrition after that piece? So that's the time at which we really want to focus on, again, kind of reestablishing a general healthy diet that is not only focused on still maintaining weight, maintaining nutritional status, getting a good protein, but also really optimizing the diet in order to help with reducing risk for recurrence or reducing risk of another cancer occurrence. So what I have posted up here is these are the cancer prevention recommendations from the American Institute for Cancer Research. And this is what we focus on. These are the set of the most evidence-based recommendations for cancer prevention in general, but also that risk of recurrence or occurrence. So within this, the biggest ones that we tend to focus on is trying to eat a diet that's very nutrient diverse and very nutrient rich. Again, with that one of those very first slides where we talked about the plants plus the protein, we're really focusing on emphasizing those plants and emphasizing the color and the variety within those plants. Some of these other recommendations, limiting the consumption of fast foods or other processed foods that are high in fat, starches, or sugars, limiting consumption of sugar-sweetened drinks. Those are not necessarily because those foods are quote unquote bad. It's more that they're very nutrient poor. If you think, I always throw Twinkies under the bus, but a Twinkie is very calorically dense, but there's no nutritional value to it. So it's not going to provide us with any benefits, whereas we could have the high calorie smoothie that might give us the same calorie volume, but there's going to be a lot more nutrients involved. So when we kind of talk about survivorship, the main thing I want to think about is nutrient dense versus nutrient poor. And that becomes a really good way to focus on eating versus like high calorie, high protein, low protein. Because at that point, usually, appetite is something that, you've kind of adapted to eating more in the way after surgery, a few months out. And it's something where we can focus more on that nutrient density, and that's going to provide a lot more benefit.
We're ready for our next one.
Yeah.
Look at that timing. Pour my last smoothie. No, it's perfect. Thank you. Sorry about the mess.
Do you want me to do anything?
No, okay. We're good. Thank you. Okay. So we're making a Waldorf salad. So Waldorf salad, this is a fantastic salad, and it's a great way to get those fruits and veggies in. So I've already done a lot of the prep here because it is time consuming, but it's worth it. This is great for survivorship. Again, trying to find ways to get fruits and vegetables in, but it can also be helpful during treatment. How often do you hear that people say, I don't want to eat anything but fruit? It's the only thing that tastes good, or it's the only thing that's appealing to me. It's like, well, that's wonderful. Not a ton of calories in there, and we're always looking for more calories in those kinds of situations. So a Waldorf salad, we can add a little bit of mayonnaise to it. We can really pack it in with maybe some dried fruits and some nuts so that you're still enjoying the fruit but getting the extra calories and protein too. And it's also pretty, there are things that it's pretty versatile. That's the word I was looking for. Things that you can add to it. For this, pretty traditional, pretty classic salad. So we have our apples. Got 6 cups of red and green apples, a good variety. So you've got the tart green Granny Smith apples and some nice sweet Honeycrisp apples. We've got some grapes. We've got celery, which is what I'm chopping right now. But maybe we could add some herbs to this, either because you prefer the flavor or it's nice and a nice palate cleanser for you. when Caitlin was talking about those taste changes and how difficult it is because there is no medication, along with the salt and baking soda rinses, something that can be really helpful for cleansing your palate in between bites would be a mint tea or a green tea. So adding a little bit of mint to this salad can be really refreshing also. Or maybe you like basil, or maybe dill wouldn't be a terrible idea, right? Parsley. And then you're adding some green to it too. Fruits and vegetables, the reason that we don't focus just on greens, like Caitlin was saying, is that all fruits and vegetables are worth it. They all have phytonutrients, and you can't get everything that you need from any one food. Is kale a superfood? Sure. Is broccoli a superfood? Sure. What about butternut squash, though? What about tomatoes? They all have their benefits, so eating a variety is really a good idea. Just a little bit more celery.
And the more color you have, also it can be more visually appealing to eat, which can also help with appetite as well.
You bet. Good point.
And it makes it more fun.
Yeah. Okay, almost done with all of that prep work. Just a few more grapes. Great. So I'm gonna make my dressing here. And for this, we have 1 cup of plain, this says non-fat yogurt, again, with dairy. If you need the extra calories, switch to full fat, which I believe that I have in this case. No, it's low fat. That's okay. Nope, smoothie. That's got smoothie on it. I don't think pineapple would taste bad in this at all, but let's not. If you have any allergies, any food allergies, this does have walnuts in it, and then of course dairy. Surely there's a faster way to do this. Thank you all for your patience. You know what I didn't bring? A whisk. You're going to see me haphazardly stir all of this with my tiny little spatula here.
Potentially you want a fork?
Yeah.
I'm going to go get a fork?
Yeah.
Okay.
That'd be great. Thank you so much.
While mixing that, can I ask a question?
Uh-huh.
Is there a difference between juicing and blending? Like,
Absolutely.
more
Absolutely.
benefits to what?
It depends on what your goal is. So if you don't have a lot of room in your remnant stomach, juicing is probably going to be the way to go because you're getting good nutrients from that. But otherwise, we need that fiber. So doing a smoothie, a puree, a blend is going to be recommended for most people. Yeah. Did you have anything to add?
Nope, I agree.
Okay, great. All right. 1/4 cup of mayonnaise. Thank you very much. Thank you. No brand affiliation here, but I am from Texas. Texas. Anybody else here from Texas? Oh. Hey! I'm from San Antonio. What about y'all? Houston. Well, howdy. All right. You'll forgive me for using the same spatula for the mayonnaise, won't you? We'll give it a good wipe. And what do we say here, a 1/4 cup? I was just lamenting to Caitlin. I moved out of the house when I was 18 years old, and I had the same set of blue plastic Walmart-bought measuring cups until Christmas this year. And then the elf on the shelf, or somebody who was getting into mischief, just disappeared my 1/4 and my 1/3 cup measuring cup. Couldn't find them, looked for weeks. So I bought a new set of these little metal ones. Guess what's missing? My 1/4 cup. Cannot find it for the life of me. So I'm using a little 1/8 cup. I'm using 2 of them. But it's more time consuming.
Caitlin, can I ask you a question?
Uh-huh.
The difference between Duncan syndrome and post-geriatric hypoglycemia. that the same thing? Isn't that the newer name between that? Because I was told I had dumping syndrome because I had a total gastrectomy. The paramedics came out to my house 3 times. I did not understand the whole food carbohydrate. I still don't know how to do the carbohydrate sugar thing, but my blood sugar went down to 33. The lowest it's ever been is 28 and 42. So the latest that I had heard is there's no such thing as dumping syndrome. It's actually post-bariatric hypoglycemia, and you can die of hypoglycemia.
Yeah.
You can't die of hyperglycemia, but you can die with that. So I would like to know, I have been, again, told to diminish your post-bariatric hypoglycemia is to do vegetables, protein, carbs in that order. Even doing that, sometimes my blood sugar will just hit 225 or 230. When I know it's over 225, I know 100% I'm going to get dumping syndrome. And sure enough, my blood sugar will drop to 44. I don't feel it until it's in the 40s. Wow. 50s, I don't feel it. In the 40s, I feel it. Is there any other way to decrease that? Because I'm sure other people have heard that. Other people here probably heard of dumping syndrome, but it's not dumping syndrome. It's actually hypoglycemia.
Yeah, and that would be like the late dumping syndrome. I haven't heard it referred to as that kind of in my practice, but it's something where physiologically I would say it is the exact same, where you're having kind of that drop in blood sugar, after that kind of peak. The biggest thing, I would say protein and fiber is going to help just slow the digestion, which, depending on what type of carbohydrate you're choosing, if you're doing like a white rice versus a brown rice, the white rice is probably more likely to cause that spike and then that subsequent drop than something like a brown rice or like a potato with the skin where you're getting in more of that fiber piece. But that's for you, that's where like a food and symptom log could be very helpful, where you're, writing things down and then kind of watching, and if you're using like a continuous glucose monitor or just, yeah, like that's a really helpful tool to be able to identify kind of how your body individually responds, kind of when we're talking about any sort of blood sugar issues.
Right, because to decrease that, you want to use the protein and vegetables, but as we know, protein and vegetables, you lose weight. And I've gone from 230, I'm down to 125, and I'm really struggling to gain weight. And I know I have the malabsorption, malnutrition, even though, you do try to eat. So I was just asking my sister Debbie, you're talking about high fat, but then you're like, oh, don't do fast food because that's high fat. Well,
yeah, and a lot
high fat is high fat. So I don't do fast food. Matter of fact, if I don't make my own food, I don't trust other people's foods. Mm-hmm. Of course, here is fine because, they know what they're doing. But it's, I'm very, I guess, afraid of other people. Like, what are you putting in there? Anyways, so my question was post-bariatric hypoglycemia. So just if you have that, if you're having those symptoms, your blood sugar is probably really low. Get some sugar in. Now, I'm not talking about 16 ounces of orange juice. Just 4 ounces just to get you back up. But just please don't, because you can die from. Yeah,
and being able to monitor for those symptoms and know, and that's kind of when we educate patients before surgery. It's like, hey, these are things to look out for because sometimes you get a team that's most surgeons are very good, but they stop following you after a period of time. Like once the surgery's done, like their job is done, and you kind of go back to your medical oncologist who may not be familiar with kind of the nuances of some of the surgery. So I think it's being a good advocate for yourself and saying like, hey, something doesn't feel right. And then kind of knowing what tools, like having the continuous glucose monitor, or being able to get somebody that will listen to you and track these things can be very, very helpful in just kind of determining your care and what's needed to stabilize that.
I hope there are no raisin haters here. But if you are, cranberries would work great too. All right, we've got most of our ingredients in here. I've got my dressing done. I am going to add walnuts. I tricked myself into loving broccoli. I used to hate it, but I told myself every time that I would take a bite, it's like, this is so good for me, I love it. And you know what? Eventually it worked. I'm still working on that with walnuts.
I'm not a big walnut lover either.
Right?
Except in baklava.
But baklava, oh yeah. But that's a question that look at that, I eyeballed it perfectly. I get asked a lot about, okay, eat more nuts, snack on some nuts so I can get some extra calories, and which nuts should I eat? Does it matter? What's the healthiest nut? It's like, well, walnuts have, it's a good source of omega-3 fatty acids, but almonds are going to be a little bit higher in protein, and they've got a little calcium in there too. And peanuts are higher in protein, and there's antioxidants in pecans. So really, just what do you like? What kind of nuts are your favorites? What's going to get you to eat more? And go for that instead of focusing on what the healthiest is. And then if you are if you're up for lots of different kinds of nuts, buy one of those fancy mixed nuts mixes. Switch it up. Doesn't have to be any one thing. Just like with the fruits and vegetables, we want variety. Actually, I'm going to add that last, I think, so we can keep a little bit of the crunch from it. Okay. So I've got all my apples, my celery, my raisins, my grapes. This dressing was, well, you can see it up there. So we've got our plain yogurt. Again, we're using, well, this is actually a regular yogurt. So we need more protein, we'll do the Greek yogurt. But the regular yogurt is going to be a little bit thinner, maybe a little bit tartar. So again, maybe what I was saying earlier is that sometimes you're craving very specific things during treatment, after treatment too sometimes. Maybe it's not the fruit that's so appealing to you, but you just want something tangy. This plain yogurt is going to be tangier than a Greek yogurt also. All right, so, and likewise, we added some fruit juice, some orange juice as the sweetener in this particular dressing, but oftentimes the recipe will call for plain sugar, so that's per your taste also. That orange juice is going to give you a little bit more tang, little vitamin C, little potassium.
Molly, we have a question.
Yes, ma'am.
Hi, thank you, ladies. I just wanted to raise awareness on the importance of registered dietitians. Before having a daughter who is almost graduating in May and then sitting for her RD exam, I thought I could ask my regular doctor, my primary care, about, losing weight, eating healthy, and they're not trained in that. They're just not. Surgeons are not trained in it. MDs are not. They have their own specialty, and that's what we respect them for and go to them for. But I just wanted to stress, not only for the patients here, and my husband has a question, but also for the caretakers, that we need to eat healthy. We need to maintain. And my daughter's always like, Mom, what have you eaten today? And I'm like, I had yogurt with walnuts, and then I had, and she'll tell me, the reason why you're tired is because you're not eating all of the things you need to eat. And we can't just get away with having some toast and butter or just a slice of pizza, because we need the nutrients just as much as they do. And it's also not well known. Like, people don't know that they can have an RD. We can have an RD giving us our food plan and have it covered by insurance with just a copay. So I'm seeing an RD virtually. They look at my food plan, they have me take notes, and it's just something that everyone needs, but unfortunately, it's not that popular. So I give you guys a lot of credit. The education is intense. Sometimes it looks like my daughter's studying for, her MD, like the science behind it. She reads all of his labs and is like, Dad, this is what you need to eat now. So I just have a lot of respect for the work that you do. And it's underappreciated. I just wanted to share that. Thank you.
Thank you very much.
Thank you. We'll arrange payment afterwards. Thank you for that. Oh my goodness.
Quick
We
question.
feel like we do important work.
Quick question about liquid hydration. What about beef and chicken broth?
Yeah.
Because I've been hearing about using that as a substitute for protein and things like that.
Yeah, it depends on the type of broth. Like, if a standard chicken broth, you're gonna get a little bit of protein, but I heard someone say bone broth. Bone broth is gonna give you a little bit more because of the higher collagen content. Is it as much as eating a piece of chicken? No, but it's kind of, if you're trying to work more protein in, and depending on what type of diet you're on, kind of what you're tolerating best, any sort of side effects, something like that can be a great way to get in a little bit more protein. Again, if we add incrementally over the course of the day, it all eventually adds up. And also there's sodium in it too, which something, if you're not eating well, or you're having vomiting or you're having diarrhea, you lose sodium as part of that also. So sometimes that can help with replenishing the sodium electrolyte as well. Yeah.
Awesome. Thank you.
And the taste too, so many of the supplements like the Gatorade, the Drip Drop, the Liquid IV, they're all sweet. And so sometimes it's nice to have something that's not sweet because you kind of get tired of sweet, especially if you're consuming a lot of it.
We have another question.
I was going to wait till the break to ask you, but maybe other people are going through this. So this happens to me quite often after I eat and I'm trying to gain weight. So I'm eating more food, pushing the envelope a little bit every time. But it seems like after I eat, even today after lunch, I get kind of like tired. I get tired, but it only lasts for about 15, 20 minutes. I think I would feel, I'm being recorded, geez. Like my heart will race a little bit. Sometimes a little sweat, but very little. And then 15, 20 minutes, it goes away. So I don't really know what that is.
Part of it could be that dumping syndrome, just kind of depending on what your GI anatomy is currently. If things are moving very, very quickly from the mouth into the small intestine, it can cause some of those symptoms to occur. So part of it, if you're noticing, again, I'll push for the food and symptom journal again, because if you can kind of write down what you're eating and say, oh, maybe you had some of the mango sorbet, and maybe even though you had the salmon and you had some of the other things that were out there, maybe that mango sorbet was the thing that's going to cause those dumping syndrome symptoms to occur, even if it's not a large amount. So tracking that and seeing, if I eat this or what combination of foods, maybe it's not about a particular food, but it's more about the combination. That's where I think the value of working with a dietitian, like after surgery, and being able to kind of work through some of these kind of individualized things, that it's not one size fits all when it comes to our digestion at all.
So since it only lasts, like I said, 15, 20 minutes, it doesn't bother me that much. So I keep doing this, or what do I do? Is it bad if I? As long as your blood sugar isn't dropping into like the 30s, the low like that, which that is more of like the couple of hours later, generally where we see that. I think it comes down to individual tolerance. And I talk about a lot of the side effect management too, it's kind of what is your threshold? Like if you're like, I notice this, it's kind of a, annoyance, I notice it, but I get through it, then it's not as big of a deal. But if it's like you're completely laid out, you feel like you're profusely sweating and it's really impacting just your daily routine and your quality of life, then that's where I think that it's a lot more reason to kind of push for changing things or kind of even diving more and being more aggressive with trying to manage it. Okay, thank you.
Welcome.
Hi, thanks so much. This is so informative. How can we manage nutrition if we're at risk for other comorbidities like diabetes or cholesterol?
So I'd say it depends. If we're thinking of like survivorship, like long-term, like after surgery, a lot of those, that same little, I don't know if I can go back on here. So this set of recommendations, the cancer prevention recommendations, what's very nice with them is that they very closely align with other kind of health promoting diets. So the DASH diet with the Mediterranean diet. So there's other things that make this unique to cancer, but when you look at it overall, it's very much plant-based, good sources of protein, trying to maintain a healthy weight. So with these different recommendations, if we're focusing on including more plants, that's reducing the risk for diabetes, for cardiac disease. If we're limiting really high-fat, nutrient-poor foods, again, those are things that typically increase the risk of those other diseases. So the biggest thing I would say is colors. It becomes the most important thing. That's really just going to help to get in a good variety of foods and help to just kind of optimize your health and optimize your nutrition overall. Not just from a cancer perspective, but just kind of from overall health.
Great, thank you.
You're welcome.
I'll add to that a little bit. It does happen sometimes, particularly during treatment, but afterwards also if you're struggling to get calories in, we really shouldn't be trying to manage your blood sugar with the diet. If you're having difficulty swallowing or you're just so full that you can't handle a lot, we really have to optimize those calories, optimize the nutrition. There's something that we can do about managing your blood sugar medically. And so we often point you back to your primary care, your endocrinologist, to help get your blood sugars better controlled so that we don't have to focus so much on the diet. Any other questions, or did you have?
Do you have anything else about the water salad that you wanted to mention?
Yes. So you can definitely chop this smaller. You want to make sure that you chew really thoroughly. But this is kind of a medium dose, but that is going to be important if you are post-surgical, just to make sure that this doesn't take up too much room in your stomach, because fiber-containing foods are going to take up more room. So chewing your food really thoroughly helps. That's actually good advice for everybody, right? Because our digestion begins in the mouth. There's some enzymes in our saliva that help to break down some of those carbohydrates, but our teeth, that mechanical digestion, the chewing of it is really important, so that by the time that it gets to your stomach, there's not as much for it to do. So in that situation, she talked about the mindless eating when you don't have an appetite, but when you're feeling better and you're eating pretty normally, you have a pretty good appetite, then mindfully sitting there and chewing and enjoying your food to make sure that it's thoroughly chewed before you swallow it is important.
Okay, awesome. All right, so for the last piece of this, so I just wanted to talk a little bit about the emotional side of nutrition. As I mentioned before, nutrition, the nutrients that are in foods are very important. Obviously we think they're important. We're dietitians, otherwise we wouldn't be in this area. But there's a lot of emotion that's tied into what we eat, both positively and negatively. We talked some about kind of eating in a positive surrounding, in a stress-free environment in order to enhance appetite and enhance what somebody's eating. Really, hopefully all of us in general are not eating in stressful environments regularly, because it's just not a good way to eat. But especially, following a cancer diagnosis, of all cancers, I would say, but especially after surgery too, and a cancer that affects the GI tract, that anxiety that exists around eating tends to be elevated much more than it is in some other disease states. So just talking about the food anxiety and the fear of the occurrence of symptoms, fear of pain or discomfort, getting tired of the trial and error. We talked a lot about experimenting, getting tired of, doing the experimenting and just wanting to find something that works consistently, or even the social isolation that can come with eating differently, with having to eat different foods, having to spend more time chewing, whatever it is. There can be a lot of food anxiety and fear of the occurrence of symptoms with these different things. Also grief. We don't think a lot about grief when it comes to food, but grieving the loss of enjoyable food experiences or traditions. We talked about Thanksgiving, not being able to eat that huge Thanksgiving dinner, but having to eat smaller portions, and maybe the people that you're around are still eating that huge Thanksgiving dinner. So even though it's not a time where you would typically think about that, sometimes it can be a thought in the back of the mind still. An emotional impact of any sort of dietary restrictions can weigh a lot on your mind as well. And there's a lot of cultural and social impacts that food has, depending on where we live, in our country, our ethnicity, where we grew up. And that can be kind of a grief when you lose some of those things too, because of your new digestion or kind of any sort of intolerances that you have. Body image and self-esteem can be a big thing. Seeing physical changes, if you have experienced weight loss or even weight gain, but physical changes and seeing, just when you see somebody you haven't seen for years and they say, oh, you look great, how'd you lose all that weight? And you're like, not the way that I was hoping to. So that and having to then go back and recount that whole experience can carry a lot also. And then depression and anxiety. Chronic illness or any sort of cancer diagnosis can take a huge toll on just overall your mental well-being and your emotional well-being, and also mental fatigue from managing symptoms constantly. So what do we do about this? Because we just talked about a whole lot of negative things. But practicing mindful eating, and not mindful eating like we've kind of talked about, like chewing well or mindless eating, but focusing on small wins, focusing on small positives. So focusing more on what you can do today versus what you can't do. It's something that takes time. It's not going to happen overnight, but the more that you do it, the easier that it gets. Connecting with support groups and peers, like in an environment like this, other people who understand what you're going through, and you can kind of share stories and say what's worked for you, or kind of in your local area, there are a lot of support groups that exist, and I think there's a lot of national support groups that exist now too, but trying to find a good network of people to provide that support. Working with a dietitian to build confidence. And I'd also put in here, we have using counseling or cognitive behavioral therapy to reframe thoughts about food and symptoms, but both really play a critical role, because if there are certain physical symptoms that you're having that could be related to nutrition in some way, shape, or form, that's an important piece, but so is kind of the mental piece of it that helps to kind of normalize or kind of untie the stimulus from the food and focus on other things, like through the use of cognitive behavioral therapy. So really just kind of trying to take a holistic overall approach in trying to improve nutrition and kind of set you up again for success. So overall, just in conclusion, making nutrition manageable, I've mentioned the food and symptom. I think that's our third common theme is a food and symptom log to identify any triggers that are specific to you. Preparing simple, easy to digest, and easy to consume meals ahead of time. Again, setting yourself up for success. Incorporating small, manageable lifestyle changes over time. That both comes into play if we're looking at diet restrictions or kind of post-surgical diet changes, or we're looking at like survivorship and trying to improve, just kind of our diet and our well-being moving forward. And celebrating small wins and focusing on what works. So with that, we'll take any additional questions, and this is just a picture of our team of dietitians. So we're very fortunate to have a whole bunch of us, which is really great, to have a really good team to be able to collaborate with. So thank you guys.
Thank you, Caitlin and Molly, for all of your great information, and thanks for the big plug for RDs. Also, I want to do another little plug for you guys. HSA and FSA plans cover you guys too. So if you have an HSA, if you have an FSA, this is a service that you can get reimbursed for. I mean, it's a no-brainer. Mm-hmm. Just do it.
I'll say a lot depends on insurance.
True,
That's
right.
We're very lucky. We come with no fee. So like when we see our patients, they're never charged to meet with us, whether we meet with them 1 time or 50 times. It really doesn't depend, which is great. We're very, very lucky. But there's not reimbursement for oncology nutrition services through Medicare, and that dictates a lot of coverage through commercial insurance plans. So I know you guys are going to Capitol Hill tomorrow.
But if you have those other 2 things, you have that's a backup.
Yeah.
So you can get it one way or another.
Yeah.
So we're going to break now for 30 minutes, and we want to give another round of applause for Molly and Caitlin. Thank you so much for being here. And we have snacks outside.
Thank you.
Okay. Hey guys, we are going to go ahead and get started. My name is Arusa Khalid. I am a stomach cancer survivor, longtime Hope for Stomach Cancer fan. I show up every year. So our next speaker today is Joe Bullock. Joe is the Chief Operating Officer of Man Up to Cancer, a foundation dedicated to supporting men emotionally through their cancer journeys. His personal journey with cancer began in 2018 when a routine colonoscopy led to a diagnosis of stage 3B colorectal cancer. Following extensive surgery and 6 months of chemotherapy, Joe experienced depression but found strength through therapy and support. Declared cancer-free in 2019, he turned his focus to the lack of mental health resources available to men facing cancer. At Man Up to Cancer, Joe helps redefine how men approach their diagnoses, ensuring that they receive the emotional and peer support that they need. His work aims to break the silence and isolation that often accompanies a cancer diagnosis, encouraging men to stay engaged and connected through community-driven support programs. So, without further ado, please welcome Joe.
Well, thank you for having me. So, it's interesting. A couple people have asked me, do you feel uncomfortable being around a different type of cancer? And I mean, I was colon cancer. I'm a colon cancer survivor, so it is in the GI area, right? But as I've gone to speak at different cancer types, because Man Up to Cancer, we are a pan-cancer organization, so we support men going through any form of cancer. So, and I go to these events and I hear different terminologies, and so the terminology I've heard out in the crowd has been dumping. I didn't know what dumping meant. So I had to go look it up, and I thought, that's like a rough Saturday night for me. So now I understand what dumping syndrome is, and I appreciate what you all go through. But it's interesting when you go to all these different cancer types, you all kind of have, it's like no evidence of disease, right? I had to learn what that meant, when I was diagnosed. So I hear people talk about being Ned, and at first I thought they said dead. But then I learned, no, they're saying Ned. So it's all these different terminologies you do learn. But thank you for having me here today. So I'm going to start out. I wanted to share a few things that I've learned, a few facts from the National Institute of Mental Health about depression and cancer. It is known that one out of every 4 people who have had or had cancer also experience depression. It can happen at any point during your cancer journey. For some people, depression starts soon after diagnosis. For other people, it can start in the weeks or even months after cancer treatments have ended. There is also a 50-50 split between men and women who have faced depression after a cancer diagnosis. It is also known that about 60% of the people who have had depression don't seek support, in part because of the stigma of depression. If you had depression in the past, you more than likely will experience it again after your cancer diagnosis. As we know, there is an epidemic of male loneliness. Many men rely solely on their spouses or partners for emotional support and social connections. 15% report they have not a single close friend. And that's exactly where I was when I was diagnosed with cancer. So most of my relationships were based on, I was a band parent, so those dads were my relationship. I was a teacher, so those dads were my relationships. I really had no really close male relationships. So when I was diagnosed with cancer, I went through a lot of, you know what ghosting is. So I went through a lot of ghosting. We understand. So I want to, the first picture here is my friend Brian Brave. So Brian was like one of my first real friendships that I met through Man Up to Cancer, actually. But we actually lived 3 miles from each other. So it took me joining an organization like Man After Cancer to meet my neighbor. So Brian is a great buddy. Brian and I go for walks regularly together. We talk about what's going on in each other's lives. Brian is actually a stage 4 kidney cancer survivor. This past year, he had a scare with prostate cancer, so he and I on our walks together would talk about what he was going through, what I was going through over the last 5 years. We've been together the last 5 years as friends. Through all of my treatment, through what I would go through with follow-ups, CT scans, and things like that, because even though you're cancer-free, you still battle, right? You're still dealing with those CT scans every 6 months, and you're still dealing with the blood work and the scare of reoccurrences. So to have someone who can relate to that is extremely important in your cancer journey. And so Brian was that for me in a lot of ways over the last few years. It is relationships like Brian and myself that is the core mission of Man After Cancer. Our ultimate goal is that no man should have to battle cancer alone if they choose not to. And it's because of these peer-to-peer connections that is why we exist as an organization. That's a lot of me. I just want to say, apologize. No. As you said, my name is Joe Bullock. I'm married to my wife for 32 years, Michelle. We live in Durham, North Carolina together. We have 2 adult children, Joshua, age 20, Megan, age 25. We also have 3 pitties that we rescued. One of those dogs is also a cancer survivor. She was a dog that actually, when I was going through treatment, she was my emotional support animal. But she's been found recently to have 2 cancer surgeries, removing a tumor from her leg and her head. But she's a survivor, like me. And as we spoke earlier, I was diagnosed in May 2018 of stage 3B colorectal cancer after a routine colonoscopy. I walked into a routine colonoscopy not knowing that I would walk out a cancer patient. So I was completely shocked. I had GI issues for a couple of years, but in my mind, I thought I was too young, even at age 50, for colorectal cancer. So during my colonoscopy, my doctor found 2 precancerous polyps and a 10-centimeter tumor in my colon. I had surgery to remove the tumor. The surgeon was actually able to reconnect my colon, but it removed 50 lymph nodes. During the surgery, 3 were found to be positive for cancer. After the surgery, I went through 2 forms of chemotherapy, oxaliplatin and Zendola. And after that, I became known as what is called no evidence of disease. And as you see here, this is my first, I just got my port in. This is my first chemotherapy. I had the mindset of like a gladiator, like I'm going to get through this, right? But because of the depression that was going to happen, not me realizing that's where I was heading, that armor was being hit and it was falling off, and I'll allude to that in a minute. But my wife made me this shirt because she kept hearing me say, I'm just going to do it. I'm just going to get in there, and we're going to get through 6 months and get to the other side, and I'm done. So she made me this shirt, and she made me a shirt for every infusion. I did 8 infusions, and so she made a shirt for every infusion. So it was kind of fun. The oncology nurses always want to know, what'd your wife make you this time? And so it was a really neat thing to do for my wife. It was a way for her as a caregiver to support me, honestly, because I know it's hard sometimes with caregivers to find ways to support the patient, and that was her way of doing it. So this is a hard photo. So when I was diagnosed my daughter's second year of treatment. My second year of treatment is when I was diagnosed. Of her second year of college, I started treatment. And her first year, when she moved in, we did everything every family does. The wife and the daughter go up to her room, decide where they're going to put everything. And the dad lugs all the packages out of the U-Haul. You know, so that's what my son and I did. But this year, I couldn't do that. And that's part of when you, as a patient, especially for a man, you start to lose that identity as a husband, as a father. I couldn't even get up the steps. My son had to go up and tell my wife, Dad can't get up the steps. The neuropathy was so bad, it was all hitting me. but I just wanted to be there. I wanted to be in that moment. So this is actually 3 weeks later, we had gone to a family day where you go and your child shows you all the things they've done. She wants us to meet all her professors. She wants to meet all her friends. I lasted about an hour that day, and my wife was like, go home, go back to the hotel, rest, come back for the dinner. And I just felt so guilty because I couldn't be there in that moment with her. And I'll never get that moment back again. And that's the problem. You never get these moments back again. So that was really what was starting to tear me up inside. So what happened was I went back home, and I'd gone to my next oncology appointment. And my doctor came in that day, and he was getting my stuff together, finding my scans, blood work, everything. And he needed to find one more piece of it. He walks in and looks at me, and he just puts everything down, and he looks at me and he goes, we're not even going to talk about this right now. You're not the same person you were 5 months ago. And he said to me, I told you 5 months ago, I've got this. And I need you to believe that. So in that moment, he was putting aside my treatment, but he was starting to treat the whole patient and not just the disease. So for me to have that as an example is kind of incredible for me personally at that moment. And it's really what spurred me to do the work I do today, was that moment with him. So this is my buddy next to me, Trevor Maxwell. So today, as we said, I'm the CEO of an organization called Man Up to Cancer. It was founded by Trevor Maxwell, the guy next to me. Trevor was diagnosed at age 41 with stage 4 colorectal cancer. Trevor and I bonded over the shared mission to support men who might have struggled the way we did with our mental health during the treatment and survivorship of cancer. Our foundation seeks to support men emotionally, no matter the type of cancer they may have been diagnosed. We have found that studies have shown when faced with cancer, women tend to reach out, men tend to check out. This leads men down a path toward mental health problems, strained relationships, and poor medical outcomes. What started out as a simple Facebook group for male cancer patients, survivors, and male caregivers called Man Up to Cancer, the Howling Place Group, has grown over the last 5 years into a nonprofit organization with 3 programs to support its membership. Trevor has a great video on YouTube. If you look Trevor Maxwell on YouTube, there's actually a video about the tree. The name of the video is In the Tree, I See Myself. And I've made a couple of pilgrimages to see that tree. And it's sort of like his version of the giving tree and what cancer patients go through in their cancer journeys. So if you get a chance to look at that, it's a pretty moving. He wrote an essay about it, and they turned it into a video. It's very moving. It always gives me goosebumps. As a leading support community for men impacted by cancer in North America, we offer peer-to-peer support, an annual men's retreat, a chemo care backpack program, learning opportunities, and we have more than 50 local chapters geared towards the quality of life of our members. And so some of us here, one person with us here today, and I want to ask Frank to come up and share a little bit. And really the reason I'm here today, Frank came to one of our events is called the Gathering of Wolves. So you obviously have seen that we have the Wolfpack logo. We believe, Trevor did an extensive study on wolves before we even started the organization, how they take care of each other, how you have men that lead the pack, men in the back, men in the middle. So we kind of use that terminology and that idea when we created the organization. But I want to give Frank the opportunity because he was at the Gathering of Wolves this year, which is our large annual event. And he's also received a chemo care backpack. So I wanted you to hear his perspective as someone who has been through what you have been through, but I wanted to share his perspective. So thank you, Frank.
Right. So my name is Frank Blandon. I'm 37 years old, and I was diagnosed with stage 4 stomach cancer back in March of 2024. So I found out about Men Up to Cancer by, of all places, on Reddit. I was posting something. Somebody said, "Hey, you should join this Facebook group. With men with cancer, join the group." I requested a backpack. I got this backpack with a bunch of goodies. And actually, I still use that backpack every time I go to the infusion center. And then from then on, I went to the Gathering of Wolves last year in September, I think. It was for me, it was a great event. It was actually be able to meet a lot of the people that I've been talking to on the Facebook groups similar to this event. And then I also met some friends that I talk, like my friend Bill, that I talk to him pretty much on a daily basis most of the time. I ask him, things that he's going through, things I'm going through, treatment ideas or whatever. And so to me, to be able to meet somebody else, who's also a young guy, to be able to meet them in person, have that connection was a great deal. And also, just like this event, it just made me realize, I guess, how important it is not just to, not to be alone, but also not to feel alone, that you had to go through it, by yourself. So, and that's kind of what Men Up to Cancer and Hope for Stomach Cancer has given me, is just that feeling that, I'm not doing this by myself. So, yeah, that's
awesome. Thank you, Frank. Thank you so much. So one of our programs is the Chemo Care Backpack program. It was developed really after an experience I had as a patient. I came home from chemotherapy one day, just really rough. You all know what it's like. I was exhausted. I had driven myself that day, and I got home, and my wife was like trying to get me, "Why don't you eat dinner? You're going to get nausea. Your nausea is going to worse if you don't eat something." So I was like reluctantly, begrudgingly ate dinner and some of it, and she's like, "There's a package, on the table. Why don't you open the package? I think it'll brighten your day." And so it was just a package of some care items and an anonymous note for someone. And it really did make that really what was coming to be like one of the worst days of my life. It was probably my third round of chemo. It was that day with the oncologist in his office. And it just made me feel really good that day. And I told myself at some point, I want to give that back. I want to figure out a way to give back. And luckily with Trevor starting the foundation, he helped me figure out a way to do that. So we started the Chemo Care Backpack program. So the lady that's on the far left over there, her husband, Brent Call, died about 3 years ago from stage 4 colorectal cancer. Now, I say that. He didn't die of cancer. His heart gave out. So one of the blessings for her was that really it wasn't the cancer that took him away, and they fought so hard against. So she had sold their home last year and wanted to use some of the funding from that to buy some of the Chemo Care backpacks. So she bought 40 backpacks, and we delivered them to 2 of the infusion centers and oncology clinics that supported Brent's journey. So I told her, I said, "Well, I'll bring them to you." So I drove down to Greenville, South Carolina, and we delivered the backpacks to both the teams at both the oncology clinics. We got to share Brent's story as well as my story and Valerie's story as a caregiver, and have that impact on those men in both those oncology clinics. And also with Brent, another story with Brent was, so Brent was the first person that I ever went to and sat with going through treatment after I finished treatment. And I remember when I walked into the door of the cancer center that day, I didn't know if I could do it. I didn't know if I could go sit with someone. Because as soon as I walked in that door, the trauma just closed in on me. And I had to go sit down for a minute. I said, "You got to get your act together." you can't walk in there. Brent's going through so much right now. And so it showed me that I guess it was that moment that I realized I could do this. I could be an advocate. I could go share with someone. I could sit with someone and get through it. So Brent was really that person that showed me I could do this. And this is one final story I have that is pretty amazing, and it really shows the impact that Man After Cancer has in the community. So this is Alex Wright. Alex had just had his CRC surgery in Houston, Texas. He had met someone very similar in the same way on Reddit or one of the platforms, joined the group, and he just did a post in a group saying, "Hey, I'm in this hospital in Houston, Texas. I just had my CRC surgery, and I'm very much alone. Can someone come reach out to me?" So the men rallied. The 3,200 men rallied, and they started posting in the group, "Hey, I'm here for you. You know, I can meet with you. Come do a video conference with me. I'll get on the phone with you." You know, it was happening all. And then we have 50 regional chapter groups. So someone from the Texas chapter group reached out to him and said, "Hey, I'll be there in an hour." So the gentleman next to him, I can't think of his name, James. So James, here in the photo on the other side, drove through horrendous rain to go visit with him, and told Alex's wife, "Go have dinner, go do something for 24 hours. I got this with him." And so they hung out back and forth for about 24 hours. 2 weeks later, Alex and James, they met with another guy from the group. They went and had breakfast together, and now they're just close-knit buddies, and they talk on a regular basis. So that's the impact, is those peer-to-peer connections. That is sort of our secret sauce as an organization. This is exactly what Trevor Maxwell had envisioned when he created, one of the mottos of our group is open heart, warrior spirit. You know, it's having enough of an open heart to accept help, but the willingness to receive encouragement, to have the strength to face the battle that is ahead of you, is part of what open heart, warrior spirit is all about. It is through these shared experiences and programs that we offer as an organization that have fostered such a wonderful community of support, because we have learned that we are stronger together as a pack than going it alone. I invite you to stop by the table outside at the event to learn more about our organization, and I'm also here to answer questions, as we'll do in a minute. We hope to have the impact on your community here over the next couple of days, and that you join us in what we know is a shared mission. Thank you for giving me the opportunity to speak today. And I know we're going to open it up for questions, so just raise your hand, and I think they'll bring a microphone over if you have a question you'd like to ask.
Hello. Thank you, Joe. We will now open up for questions. Guys, please raise your hand and wait for a microphone to come to you.
And I will say, this was from our latest gathering of wolves. So we had 150. This is the third one. So, and this is 150 men that attended that retreat, and it was in it's at the Pocono Springs camp in the Poconos Mountains in Pennsylvania. And it's just a 4-day of fun for the guys. We have a great location. They have a heated pool. They can do water polo. They can. We have a pickleball, basketball. Really, the most special time of that event is at night around the campfires, when the stories really start to happen. And for many of these men, it's the first time they've ever shared about their cancer journeys. So that was the latest one this year with 150.
Hey, Joe. I know we talked on the side before, but how are you doing today? And what steps are you taking to get better mentally moving forward?
I'm doing great. I've been no evidence of disease for 5 years. And and that's very true. One thing that happened, so I was in a support group during my treatment, and for about a year after treatment. And I remember my therapist, who led the group, pulled me aside after one of the meetings after I found out I was NED, and she said, and we hadn't met for a while because I really was doing much better. It really was the chemo. We learned that I didn't need a drug protocol, that I just needed talk therapy. So talk therapy was extremely helpful for me. And she's like, just realize that probably in about 2 months, you're going to want to give me a call and set up an appointment. You're going to hit a wall, and it's all going to flood back at you. And that's exactly what happened. Am I going to have a reoccurrence? What happens now? At least when I was on treatment, I was doing something about it. And now I'm not doing anything about it. Is the cancer still growing? And all the noise was happening. And so I ended up going back into therapy for about 3 months. And she even explained to me, and I didn't really talk about therapists as much, she even explained to me, and luckily I was at Duke Cancer Center, and they have a whole therapy side that's a nonprofit that supports cancer patients. So for me, that day when I was at my oncology appointment that day, and I was having all the depression, he came in. I didn't talk about this part of it. He brought a therapist in. He's like, look, I know what you're going through. While I go and figure these things out for a minute and find out your other blood work, can I just bring her in and can she just sit beside you? You don't have to say one word. Just let her tell you what the programs are offered. And so that's what happened. And then within 5 minutes, I just kind of regurgitated to her all of it. And then I ended up in therapy for about 6 months as I was going through chemo. And it was just a great program there. She actually would come to me when I was in infusion. Like she would say, while you're here, call me. Let me know when you're going to be there, and I'll just come sit with you for 30 months. So that's really how we set it up. But then I ended up going back into therapy because it all came flooding back. And since then, what's really helped me is building this community. When I became Ned, I made a decision that cancer might be done with me, but I'm not done with cancer. And that's what led me on this journey. Really had a passion, really seeing what I had went through, and I know there are other men that are going through it, and creating a space for them. Because I didn't have a space, and I wanted to make sure there was a space available. Yes. Thank you. And it's a community, so it's really, I say, it's developed into a complete community now. So it's really good to see it's happening.
I was just wondering if you have a chapter in Southern California?
Yes, we do. We have 2 chapters in California. If you go on our, I can give you my information. I can connect you with that person. We're actually working towards, we're hoping by April 1st to actually kind of move somewhat off Facebook. We're developing our own app. It's just we're hoping to give, because we understand that men aren't on social media, they aren't on Facebook, and we're trying to create an environment for them where maybe there'll be a chat group on the website and different avenues. Because we know we need to spread throughout it. The reason we are pan-cancer is because because Trevor and I came out of a colorectal cancer group. And we realized that if we wanted to have a larger impact amongst men, we needed to throw out a bigger net. So that's why we are more pan-cancer, and we do focus on the trauma side of cancer, not the treatment side of cancer. So when these guys come out of our group, they do talk about what they're going through treatment-wise, but then we send them back to those treatment groups to get those questions answered as far as the science goes. So our group is emotional support. We don't talk about alternative treatments in the group. We don't talk about politics, and we stay definitely and religion. Like we stay away from those things because it gets too divisive. And so the guys know that it is just for emotional support in our group.
But your retreats are only in Pennsylvania at this time.
The large one is in Pennsylvania, but we do have mini retreats. Some of the guys, we have 50 chapter groups, so we do support those as well. I think we did 14 mini retreats last year, which were like small little retreats. We'd rent out an Airbnb or find a small, another campground with a cabin. And if the guy, and these are the chapter group leaders. So when I showed the picture earlier, the 50 men, when they came to the first retreat, the one thing they told us was how can I do this at home? So we made that happen, and we formed, I think 25 chapter groups formed out of that first meeting. The guys went home. They started, I think we had one weekend this year where 5 or 6 of our chapter groups were all at a Major League baseball game. And we funded those projects so they could have those get-togethers. So yes, there are some mini retreats going on. But it really works, and these are the guys that are doing it. We're not planning them. They're planning them. We're just giving them the resources to do it.
So Joe, I had a question. I know you mentioned that there's plans to move away from Facebook, as some people don't use social media as much.
Yes.
So what are you envisioning for the future, I guess, of Men Up to Cancer, right?
The future plan is to have an app. That's what we're working on now. We're slowly moving to that direction. Working with the CRM, connecting it to some sort of, we're looking at maybe a circle type platform, and eventually developing into a full app. So they would actually have an app that they could reach out to and get support and not have to rely on a Facebook or social media. Yeah.
I guess my question was more overall as the organization itself, right, of Men Up to Cancer. I know we had the retreat, the backpack, and
Well, currently what happens if there's someone that's not on Facebook, they can reach out through info. They can come to the website, and if they can reach out through info@manuptocancer.org, and I monitor that, and then I will reach back out to them. I send like a form letter that basically tells them how they can get a backpack, how they can join a chapter group without being on Facebook. And how they could possibly join. I mean, currently, the last couple of years, to be able to vet, we've had to use Facebook for that purpose because we want to make sure these are actually cancer patients. So that has been our other avenue is through the webpage, and we do reach out to men a lot of times, and as well through that avenue.
So thank you again, Joe. Okay. We are glad you're still here and you're able to be here with us today and for the work that you do with Man Up to Cancer.
Thank you very much.
How do I turn this one off? Okay. So for those of you who were here with us in May, we are very excited to be able to bring back Erin Whalen with Compassionate Coaching and her Playback Theater session. Erin Whalen is the founder of Compassionate Coaching, a company dedicated to restoring dignity to those who are grieving and dying by creating spaces where they feel truly seen and heard. Through workshops, programs, and interactive programs, Erin supports both professionals who serve grieving populations and groups navigating grief themselves, fostering meaningful connections and compassionate communication. With a background spanning almost 20 years as a professional actress and role player, particularly in medical education, Erin brings a unique blend of performance, facilitation, and playback theater to her work. Her approach fosters empathy, connection, and healing, making her sessions both cathartic and transformative for participants. Erin's work is deeply personal, inspired by her own journey with grief following the death of her sister Gina in 2016, and her lifelong relationship with anticipatory grief. This lived experience infuses her work with authenticity, compassion, and a profound understanding of the human experience at the intersection of loss and connection. Welcome, Erin and the Playback Theater team.
This little light of mine, I'm gonna let it shine. This little light of mine, I'm gonna let it shine. This little light of mine, I'm gonna let it shine. Let it shine, let it shine, let it shine. All over this world, I'm gonna let it shine. All over this world, I'm gonna let it shine all over this world. I'm gonna let it shine, let it shine, let it shine, let it shine. This big light of ours, it has magic powers. Oh, this big light of ours, it has magic powers. This big light of ours, it has magic powers. Let it shine, let it shine, let it shine. Let it shine, let it shine, let it shine. Let it shine, let it shine, let it shine.
Thank you, Asali. This is Asali. She's going to be our musician for this evening. My name is John. Thank you for allowing us to be here. This evening, you're going to experience something called Playback Theater. And this is being live streamed, so if anyone has any issue with that, when we come and ask for any type of stories, just let us know, okay? So Asali sung a song, This Little Light of Mine, which how many folks are familiar with that song by the show of hands? Okay. That is a definition of hope for us, like light, right? What definition do you have of hope? When you hear the word hope, what comes to mind? Just raise your hand and I'll come and chat with you for a second. What is your definition of hope? Yes.
Light at the end of the tunnel.
Light at the end of the tunnel. Now, so I'm going to ask permission. Can we play back that definition? Light at the end. Okay. So when you say light at the end of the tunnel, give me a few more words that explain what light at the end of the tunnel means.
Long road.
A long road with light at the end of the tunnel. Okay, and what is your name?
Cecile.
Cecile. Okay, so we're going to do something called a fluid. So on the count of 3, we're going to say Cecile, right? That's your name? Did I say it? Yeah. We're going to say, Cecile, let's watch. And it's like a Bob Ross painting. Your story is going to come to life, okay? Yeah. All right. So on the count of 3, we're going to say, Cecile, let's watch. All right, actors, can you stand, please? On the count of 3. 1, 2, 3.
Cecile, let's watch.
I'm here!
I'm
here! I'm here!
I'm shining!
I'm here!
I'm shining!
I'm here!
I'm shining!
Thank you, actors. So, Cecile, what happens is the actors then take a moment and they make eye contact with you to thank you for your story. What was it like to watch?
It was nice putting into action what I just said.
Okay, cool. So you get it. Thank you for breaking the ice. So hope. What does that mean to you? When someone uses the word hope, what does that mean? So we heard light at the end of the tunnel, a long road. Yes. Okay. Tell us your name first, please.
Patty.
Okay. And so what does hope mean to you, Patty?
It means a sense of peace and calming and not fear.
A sense of peace and calming and not fear. So do we have permission to play back your story, Patty? Yes. All right. So on the count of 3, we're going to say, Patty, let's watch. All right? Come sit down over here. 1, 2, 3.
Patty, let's watch.
I'm not afraid. I'm not afraid. Thank you, actors. Okay, so I'm gonna come check in with you, Patty. What was that like to watch, Patty?
I could really feel it. I could feel that you had the perseverance to keep going, but that fear kept trying to come in, and you just kept that centerness. It's kind of like what I'm doing.
Thank you. Thank you, Patty. Okay, so you get it. You tell a story and it comes back to life. Now, this is our second year here. Who is here from last year? Is there anyone who would like to share their journey? A story of their journey.
In the back.
Yeah, okay. All right. Come. All right, so tell us your name.
Essie.
All right, Essie.
Okay. I'm gonna try to do this short because now it's a continue from last year. For those who was there, we saw how they did such a wonderful job sharing my story last year. So my story started in November 2022. Went to a routine colonoscopy checkup, and when the doctor finished my checkup, he said, "Your colon looks good, but I see something on your stomach that looked cancerous." So 3 days later, I get a call back saying that my biopsy came back positive. And that was, of course, the most devastating news one can hear. And so we move on to December. That was late November. So December, we take lots of tests. In January 2023, I started with Flot 4 rounds of chemo every other week. And then in March, I had more tests done that showed that the chemo was effective and that I was a candidate for partial stomach removal. So that was April 2023. And then after the surgery, 7 weeks of healing, I did 4 more rounds of chemo. I rang the bell in July 2023, which was a great feeling. In August 2023, I was declared no evidence of cancer. And then I continued to get tests monthly. And then as my tumor markers continued to rise, my doctor was very concerned. And so then we move on to April 2024. And I had got tested between January and April 2024. They tell me the cancer has returned, which was stage 4 because it was on the outside of my stomach and it was in my peritoneal area. So that was so devastating. And then I didn't want to do any more treatment. She offered me a clinical trial. And so after deep thoughts, about a month later, I started a clinical trial called STAR 221. And I'm actually still on that clinical trial. But just recently, my tumor markers continue to rise. And she told me that she want to stop the STAR 221 treatment and start me on another treatment because my latest PET scan showed that the tumor marker has enlarged a little. And so, of course, this just happened on Monday, and that was just put me back in a depressed mode that I didn't want to be in. It was in a place that I didn't want to be at. And so I'm here today. I feel good that I'm in this community, Hope for Cancer. I'm so happy my children, my family was able to come here and be with me and join me. And so I'll talk to my doctor next week. She gave me some paperwork, and I didn't even look at it. I don't know what she offered me. I know she offered me 2 clinical trials and some chemo and immune therapy, but I haven't looked at it because it was just something I had to digest. And so in the next week or so, I'll be looking at the paperwork and talking to my doctor about it and see where we go from there. But other than that, I'm in great spirits. I have my moments that I be in a dark space, but I snap out of it real fast because of them. And all of you all, that makes me keep smiling and just keep moving and fighting and pushing through. no matter what they tell me, I'm going to keep on fighting and fighting and fighting and keep pushing through. So that's my story.
Cool.
Continuing from last year.
Cool. Thank you, Essie. Thank you so much. So real quick, the importance of what we're going through now is so that people don't feel alone. So Essie, in a moment, I'm going to ask how many folks in here can relate to Essie's story by show of hands. So Essie, I want you just to look around in the room, because there's going to be a moment where we get up and we go and we make connections with other people. And it's very powerful that you're sharing this story with us. Now, there's one thing, I remember you from last year too. And one of the things you talked to me about was all of the things that you're doing, right? All of the living that you're doing. So is it possible you can share some of those stories with us so we can play back some of those stories? Last time you were talking about going on some Beyonce cruise with your friends, right? So that's what I remember, right? Right. So we just to be brief, but just tell me some of the things that you're doing, some of the living that you've been doing. Like you said, your family's here, and so share some of those things so we can highlight and love on you some.
Since last May, when I told my story, it was right. I had got re-diagnosed right before my 54th birthday, and of course, all I could think about is my birthday, and I'm going to be celebrating, having fun. All the ladies and I was dressed in silver. We did a photo shoot. Yes, it was like a Renaissance photo shoot, so it was so much fun. So that party did turn out fun. That photo shoot turned out fun. After that, I've done some more cruises. I actually just got back from a cruise last week, so I'm still cruising. I'm actually going to see I had 2 granddaughters since the last time I was here, so I'm actually traveling to California next week to see my baby granddaughter that's just turned 3 months old. So I'm looking forward to going to see her, and then I'll deal with cancer. But yes, so I love cruising, and I love traveling, and I love having fun. I love being a party. When I step in, I love the party.
Okay, so give me a title. Give me a title to this story that you just shared with me. Give me a title, and I'll leave you alone.
Never give up.
Never give up.
Keep smiling and keep smiling.
Never give up and keep smiling. So can we play back your story, Essie? Okay. On the count of 3, we're going to say, Essie, let's watch. Never give up and keep smiling. On the count of 3, Essie, let's watch. All right? 4-part. We can do a 4-part story. 1, 2, 3.
Essie, let's watch.
Keep on smiling, I keep on moving.
Hello, everybody. My name is Positive, and I know none of you like me. I am positive, and you don't want to touch me, do you? I am positive, and you think you are scared of me, huh? I am positive. Nothing will get me down. Nothing. Oh, no. Not a trial. Oh, no.
Keep on smiling, staying positive.
I am the cruise ship, the Queen Mary. I've sailed these seas for many, many years. And you want to know something? There's this woman that keeps riding in my ship. It's gotten so she's kind of like family. And I look forward to seeing her. Her name is Essie. Essie. One of these days, I think I would love for them to rename me from Queen Mary to Queen Essie.
Keep on smiling, I keep my head up.
Shh, it's all right, it's all right. Oh, I just fed you. Why are you still crying? How about this? I got some great news for you. Grandma Etsy? Yup, she's on her way. Oh, now you want to smile. And now you want to stop crying. Huh. You got to smile just like your grandmother. Huh. And you a fighter. Yeah. You're gonna be just all right.
Keep on smiling, I keep my head up.
Yeah, my name's Essie. I'm a fighter. But I'm not just a fighter. You know what else I like to do? I say par, you say tay, par. Par, tay. You say par, I say tay. 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 My name is Essie, and I'm full of life. My name is Queen Essie. I say queen, you say Essie. Queen.
Essie.
Queen.
Essie.
Woo!
I keep on smiling, I keep my head up.
Thank you, actors. So, Queen Essie, all the actors are going to take a moment to make eye contact with you, and I'm going to come check in with you. What was that like to watch?
It was amazing. I love the staff when they put it all into theatric. It's just a beautiful sight to watch. I love it, and they do such a perfect job in acting out my story. I love it.
Thank you for sharing your story, Essie. Cool. Thank you. All right. So everyone with me, on the count of three, we're going to just take a big old deep breath. So 1, 2, 3. Thank you so much, Essie. So is there anyone else who returned to this summit that would like to share their story? Okay. Cool. Are there caregivers in the room? Caregivers, raise your hands. Okay. I want the caregiver, keep them up for a second. I want you guys to look around at one another because, again, there's a moment where we're going to see if there's somebody who you might be able to make a connection to. All right. Are there any caregivers who want to share their story of this journey of being a caregiver? Okay. All right. Tell me your name first, please.
Rachel?
You can hold the mic, Rachel.
Okay.
Just make sure you speak into it. And you can start talking whenever you like.
So I have to say that I think I'm still in the denial part of the journey. And even though it's been a whole year, it's still a very difficult thing for me to even think about. I kind of stuff my face in books or video games or my computer, and if I think about it too long, I start to spiral. So I think my journey so far has been kind of oscillating between anger and sadness. And yet I see him, and I see that in many ways he's much stronger than I am. I feel like he handles it better than I do, and I feel so guilty because he's the one going through all of it.
Cool. So those folks who are caregivers, how many folks can relate to this story? I just want you to see. Just look around. So make sure that the important thing about this is to understand we're not alone in this room. You know, so that these feelings you have are the right feelings to have, right? Okay, so can we play back your story? Okay. Sure. Give me a title to this story that you shared about being a caregiver.
Oh man, it feels to me like just a storm of emotions.
A storm of emotions.
Yeah.
All right, tell us your name one more time.
Rachel.
Rachel. Okay. So, and just let me kind of reiterate. So, as a caregiver, you say sometimes you bury yourself in the books, but you also look at who you're the caregiver for and say this person's strong. Yeah. You recognize this strength in a person in a different type of way. Okay. All right. So, on the count of three, we're going to say let's watch. We're going to do another 4-part story. All right. 1, 2, 3. Let's watch.
It's such a stormy night. I think I'll just read. I don't care what the storm does outside. I'm just going to read. And I'm going to float. I'm going to be held so that I can hold him and we can hold each other. Rage if you want to. Rage.
It's all inside of me. There's anger and fear and sadness. You too? You too? You too? So you mean there's also hope.
No. No. I won't believe it. I said I won't believe it. Not you. No. No. I won't believe it. No.
I lay back and I just watch. I watch how strong she is. I watch how she helps me. I watch how she nurtures me. I watch how she holds me so lovingly. I watch how she listens to me. I see her worry. I see her anger. I see her pain. But most of all, I feel her love. And I'm so grateful. I'm so grateful.
Thank you, actors. So the actors take a moment and make eye contact with you. Thank you for being vulnerable. And they thank you for your story. I'm going to come check in with you. What was that like to watch?
It was beautiful. It really did kind of encapsulate all the complexity of the emotions and the denial and everything that I've been through.
Thank you. Thank you. All right, count of three. We're going to take a deep breath together. 1, 2, 3. Okay. So now we all have some community homework. All right? I'm going to ask a few questions, and I want folks to raise their hands if they feel comfortable. Now, the importance of raising your hand is to find community. Okay? All right. So, those folks who are caregivers, raise your hand again, please. Look around the room. Find your people, because I'm going to ask you in a moment to get up and go and approach somebody and have a conversation. Cool? Those folks who have been newly diagnosed, raise your hand. whatever that means to you. Okay, look around the room. There's some hands up. Find your people. Those folks who may be on clinical trials or had gastrectomies, raise your hand. Look around the room. Their hands up. And those folks who, if there's someone who doesn't have their hand up, find someone. In a moment, we're going to say, I'm going to ask you guys to get out of your seats and go find somebody. Hopefully you saw some of those hands that went up, and just have a conversation with them. And when the music plays again, you can find your seats, and then we'll have some more storytelling. Give it up for everyone who's been so vulnerable in sharing their stories. The reason this summit even exists is so that you don't feel alone. And this is a moment where you can find someone who may be going through something different, similar, but we all are a community right now, okay? So go find your community. All right, thank you.
Boop, 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 boop. Boop, 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 boop. This big light of ours, it has magic powers. Oh, this big light of ours. Oh, this big light of ours, it has magic powers. Oh, this big light of ours, it has magic powers. This big light of ours, it has magic powers. Let it shine, let it shine, let it shine. This big light of ours, it has magic powers. This big light of ours, it has magic powers. This big light of ours, it has magic powers. Let it shine, let it shine, let it shine.
Cool. Thank you. Thank you. Can you hear me? Okay, here we go. All right. So welcome back. How many folks were able to make a connection by the show of hands? And then you guys look around. Look at the room. Woo! That is what we're here to do. We're here to facilitate connections. And I hope you guys exchange numbers and Instagram, whatever, however people connect nowadays, you know what I mean? And continue that, right? Like, this is an opportunity not to be scared to walk up to someone and ask them some questions. And I saw some hugs. And that's beautiful for me to see. Okay, so we're going into the second half. Maybe you feel more comfortable with sharing. Initially it's like these strangers in black are sitting up here asking us these questions. We know it's going to be a little. Is there anyone who would like to share their story? Not what they say. Okay, all right, here we go. So just tell us your name first.
My name's Jamal.
Okay, all right, Jamal.
So my story started in February of 2022. Truthfully started in February 2021. It's weird. Everything happened in February for me, almost to the date. I went in, I was having pains, and was told that I had H. pylori. Went home with some antibiotics, and that cleared up. But I knew that something else was going on, so I was really adamant trying to figure out if I can get an endoscopy or get something else. And they just assured me that I had this H. pylori. Everyone gets it. It's cleared up now. You're good. So we left that alone. Shortly after that, I met Melissa, and COVID hit, and we were courting one another and getting our families acquainted. And I ended a 13-year relationship, maybe 2 years before that, and was just kind of getting back into the scene of all that stuff and just figuring out life. My relationship with God became very powerful at that time, and my children were with me full time, just trying to figure things out in life. I got into really good shape and started playing semi-pro football at 38, 39 years old. Probably shouldn't have been doing that, but I did. And I took a hit at practice to my abdomen area. And shortly after that, we went on this vacation to Florida. COVID was starting to open up, and they had like those really cheap flights down to Florida. And we were like, let's get out of here. So we got down there, and as soon as we checked into the hotel room, I went to the bathroom, and I had black stool. So we spent some time laying on the bed and looking and Googling, and right away Google just took us right down that honey hole. Cancer, cancer, cancer. And I told her, I was like, that's what it is, because I just knew I was kind of run down and tired and things like that. I just wasn't what I used to be. And so We got back home and went to the doctors, and it was February again, and they did endoscopy and did not want to do. Actually, they checked for the H. pylori again. They didn't want to do an endoscopy, and I was in the ER, and they sent me home. And I called in the morning and kind of just would not leave the endoscopy people alone. They remembered me from before and brought me into their office and were going to give me a cease and dismiss letter, said, leave us alone. So I kept calling, and they finally gave me an endoscopy, and 3 days later they called me and told me that I was positive for cancer. CDH1, and me being the person I am, I seen the reports, and I actually called to the scientists that read the reports, and I was like, what does this mean? And they were like, it's a cancer that's very hard to beat. You're going to need to get your stomach removed. If they tell you that they don't, to only keep part of it, do not listen to that. He was like, take it all away. Do not give this cancer a chance. Your only hope is if you eradicate it from your stomach. So we had a huge fear at that point in time. Around that time is when I reached out and found hope. Went through surgery in March, and they told me that they got everything. Our surgeon actually said, you can be Facebook official. We got it all. So I'm sorry, that following June. So February, surgery and chemo, then surgery in June. And then August, we got a report that the stomach had come back and that they found cancer on the outside of the stomach, a microscopic amount of cancer. So you're stage 4 and you have 12 months to live. So everything then went back to doom and fear. And we did not know what to do. And I started searching out different places. I went to NIH, I went to MSK, I went to Fred Hutch in Seattle, and just couldn't find a home that would look at me as a survivor. I just wanted to fight, and everyone was like, nope, you're stage 4. And we finally prayed about it, and someone told us about MD Anderson in Houston. And we went down to Houston, and we actually found a home there, and I started going there, and I've been NED for every single checkup from that point forward. So
first of all, thank you. What is important in this story? So I heard a couple of things, and so I'm gonna give you back some of those things, and you can say that's. You said that your faith increased. You talked about partnership, and you also talked about your journey into playing semi-pro football. Like you had a lot of things in there that are interesting. So, if we're going to play back your story, what parts of your stories would you like to play back around this journey?
I know for sure that God put certain parts there before this happened. So my caregiver, my angel, my fiance, I know for sure that had to happen for.
So what is your angel's name?
Melissa.
Melissa. Tell me some things about Melissa.
She's gentle, caring. She fights this cancer more than I ever have had to. I always know that I can fall.
Okay. So Melissa's important. You also seem like you were an advocate too. Like I'm calling people back too, right? So can you just tell us a little bit more about like your advocacy when through your journey too?
I just hate cancer. I think it's it doesn't go after bad people. It goes after good people. It doesn't ever. It's cowardly. It doesn't look you in your face and come after you. It's tricky. It's in touch with the devil, and I just wish I can see it in a person's form, so I can get my hands on it back. It's just not. So a part of my fight, and I encourage a lot of other people to be that way as well. Is I don't give it time. We don't give it time in our household. We don't chase it. We deal with cancer when it's happening, chemotherapy, surgeries, things like that. But outside of that, we don't give it any more than what it already steals from you.
Cool. And where do you give your energy then? What are the things that you give your energy to?
Life, joy, my kids, anything that I know. Every moment that we're here, we're spending that time together. So we're very adamant about love and time and making sure that when we, as humans, we don't share this as often as we really think we do. We're in our phones, we're doing these other things. So when we're watching a movie together or when we're talking, we're very intentional about that love and that time together.
So he would say we're very intentional. Like as humans
About
now,
giving
like,
our love.
Basically,
And
we need to put our phones down and be with each other in a nutshell. So tell me a little bit about your children.
Jamal Jr., he's 18, and my daughter, she's 13. The other part of my story is I did find out this is hereditary, and so I just told my 18-year-old son 2 days ago. The first time I came to Hope, and the reason I came to Hope was to find a way to tell my children. This is my third one, and this week I finally had the courage to tell my son. So he knows and got a lot of relief out of that.
Okay, so there's some relief from notifying your 18-year-old son. There's an angel in your life, and you say we need to spend time, be intentional about loving one another.
That's right.
All right, we're going to do a 4-part story. Give me a title to this story that you're sharing with us.
Don't give up.
Don't give up, and tell us your name.
Jamal.
Jamal. So on the count of 3, we're going to say, Jamal, let's watch. Thank you, Jamal. All right. 1, 2, 3. Jamal, let's watch.
I know my body better than you, doctor. I know my body better than you, doctor.
Every time, every single time they tell me no, I say yes. Every single time they said, nope, stage 4, we don't deal with stage 4, you got 12 months, stage 4. I said, you know what? Let me find somebody else. Every time I fight. Every time they say no, I say yes. Every time I fight, and I don't ever stop.
I said, I know my body better than you, doctor. I know my body better than you, doctor.
Jamal, why are you fighting back? Quit! Why do you keep fighting back?
I have an angel, her name is Melissa. I have an angel, she's in my life.
How did she guess that I was going to come up here? Because I have a hero in my life. He's wonderful. He's so good with the kids, but he's better with me. I know that he's been struggling. I know. I've been there every step of the way. I fight too. I'm not giving up either. But I tell you something, when the good times roll around, we have good times. Yeah. Mwah. Mwah.
God is on my side, and I'm so grateful. God's on my side, and I'm so grateful.
Names are so important. Mine is Jamal. My wife's name is Melissa. I've named one of my children Jamal. These names are so important. They give direction. They hold hope. Another name that's important is like this guy named Baldwin, who said about despair, I don't give in to despair because I can't tell the children they have no hope. They have hope. I have hope. Jamal, Melissa. Melissa means like honey, like sweetness. And Jamal the meaning is so important that I gave it to my son.
I have my God. I have my family. I have my life. And I'm so grateful.
Thank you, actors. Jamal, the actors will take a moment and make eye contact with you to thank you for your story. What was that like to watch?
Powerful. And so correct.
Thank you, Jamal and Melissa. Thank you. Cool. Last thing, Jamal. How many folks can relate to Jamal's story in this room? I think this is important, Jamal. All right, okay, cool. Is there another story in the room? All right, come on over here. Slide through. Tell us your name first. I'm gonna hand you the microphone.
My name is Arusa.
Arusa?
Yes.
Okay.
So I was diagnosed with stomach cancer when I was 27, and this is at a point in my life. I'm married. I'm at a place in my career where I'm finally happy. I finally feel like I have my life together, and yeah, and this happens, and it just, I feel like I had to fight every single step of the way, even getting my diagnosis, because all my doctors are telling me that I'm fine. My scans are fine, my biopsies are fine, and I know I'm not. And it took a year of me going back and literally fighting for a diagnosis to get it. And then, but that was just like the beginning of it. And it's the pandemic, and I have my surgery and I have my chemo, and the chemo doesn't work, and I'm just getting sicker, and it just felt like everything was just happening all at once. And aside from cancer, all of this is happening, and then my marriage is also falling apart, and I'm having to deal with this and this reality of like, do I want to I don't know if I am going to be here much longer. Do I want to spend that little time left in this place where I'm not happy? Or if I do get better, like, do I want to build that future family with somebody that has already proven to me he's not going to be here for me, right? And so it made it very easy for me. So it's like, I just kind of looked at my life and I'm like, I'm in my 20s. I'm dealing with cancer. I'm going through a divorce. Like, I never thought I'd be here. And I'm really grateful to be where I am today, but I find myself still very like frustrated because I feel like it's been so hard to get back to where I was. And now I'm like, how am I in my 30s trying to like start over, it seems like, and dealing with issues that I thought that were behind me. And then I feel guilty for feeling that way because I know that I'm so blessed to be in this position and to literally just be alive. So there's just a lot of like, I think I'm constantly battling this like grief of my old life, this guilt, like survivor's guilt of like, how did I make it and other people didn't? But also like holding on to like this blind hope that like there's something better for me. And if I'm here, it's because God has a plan for me. And that's for me, like I still have a purpose.
Cool. First of all, thank you. Thank you. I'm just watching you and that's beautiful. So how many folks can relate to this story? Just look around. Look around. You have community. You're not alone. All right. So we're going to do a narrative V. We're going to do something a little different. Give me a title to this story you share with us. There's a lot in the story. So just try to just whatever comes to your mind is the right thing to say. So I don't want to put a lot of pressure on you to think about it. Give me a title to the story.
Dazed and confused.
Dazed and confused. Okay. And tell us your name one more time.
Arusa.
Arusa. Okay. So on the count of 3, we're going to say, Arusa, let's watch. Okay. 1, 2, 3.
Arusa, let's watch. This is Arusa's story. I wonder, do people think I'm stupid? I've told them I'm not well, and they tell me, you're fine.
You're fine.
You're fine.
You're fine.
You're fine.
I know I speak well. I know I present well. Why is this happening?
Why?
Why?
You know, I love well. I love well.
I love
well.
And I deserve to be loved back. I deserve to be embraced.
Embraced.
I don't know why this has happened to me.
Why?
But I know there is a purpose.
A purpose.
There is a reason.
A reason.
And I'm lucky to be here. So many people haven't been. God, I'm starting over again.
Starting over.
I'm living again.
Living again.
I am going to do what I need to do. I'm going to live.
Live.
Thank you, actors. So, Rusa, the actors are going to take a moment and make eye contact with you. What was that like to watch?
It was very powerful. I just kind of felt my emotions kind of come to the surface. And I don't know, sometimes I feel like I have a hard time expressing what I'm thinking. So to see it reflected back at me was just, it was a really cool experience. So thank you.
Thank you. Can I touch you on your shoulders? Thank you. Thank you. Cool. All right. Count of 3. We take a deep breath together. 1, 2, 3. Okay. So, is there another story in this room? Is there someone else who would like to tell a story? Yes. Can I ask a question? Can we actually invite you up on the stage? Yes. Come on up. Come on up. All right. You can have a seat right here. All right, and just tell me your name.
My name is Doreen. Okay, I've told little stories. It was during COVID. Walking down the hallway for your chemotherapy. No visitors, no family, no one. You walk alone down that hallway, looking at patients left and right, long faces, crying, in pain. They're alone. With a warm blanket, the nurse goes in, the nurse takes off, and you're left alone. That was me.
Wait, real quick, pick one of these actors to play you. 1, 2, 3, or 4.
Who can be sad?
Well, just pick one.
Despondent. Sad. My gentleman, my brother right here.
Okay. Give me 3 words to describe who you are.
I'm strong.
You're strong. Okay.
I'm a fighter.
You're a fighter.
But I'm also a believer. When someone tells me something, I tend to believe them.
Okay, but you also a believer.
Yes.
Like practical and
Yes.
Okay, all right, just okay. Continue with your story.
I went through my chemo. Cancer was gone, but cancer came back. I was a fighter, fought. But at the end of the day, after my doctor told me cancer spread everywhere, we'll put you on Keytruda. It'll slow down the progression of your cancer, but it's not going to go away. You have a few weeks, 3 months to live. But that's it. Get your affairs in order. You live every day like it's your last, because this is it. I stopped fighting because I believed. And that was okay. That Thanksgiving, I said goodbye to my family, my children, my grandchildren. I said this will be our last Thanksgiving together. This will be our last Christmas together, because I won't be here next year. We went and got the lawyer. We got our fund, our trust fund taken care of, because I was done. I fought the good fight. I gave it my best. But the cancer was just everywhere, and that was okay. I was okay to die. I felt that there are some people that have never been married. I was married. Other people have had no children. I've had children. People have not had grandchildren. I've had that. So I thought this was it. I'm okay with my Lord. He wants to take me. This is the decision. I'm ready to die. Said goodbye to the church family. Said goodbye to my neighbors. Said goodbye to my coworkers. I was done. And I lived every day. There was a glimmer of hope, but it was so far I couldn't even see it. I would go see my surgeon with a long face, like, gee, what do I have? Like maybe 3 more visits and I'm done. When I went to go see him this one day, he goes, what is wrong with you? You were such a fighter. Why are you giving up? And I said, because you told me that this is it. You told me that Keytruda and my immunotherapy it's not chemotherapy. It will not cure my cancer. It'll just slow it down. And it was my same surgeon who told me, go live every day, you're going to die. He says, but don't give up. There are people who are on immunotherapy that go into NED. It's few in my practice, but I think you can be one of the few. It was then that I thought, why didn't you tell me that? What the heck? So I started to fight again, and I found that renewal from the same surgeon who told me, you have a few months to live. So with that, I started surrounding myself with people who love me. It's still COVID. There are no cancer support groups out there. They were all closed. I didn't know about Zoom. Who knew Zoom? I didn't know Zoom in 2020. There was no Zoom. I did not find not one cancer person that I could attach to. The only people I had in my life was my siblings, my children, and my grandchildren. Not one cancer patient did I know, other than the ones that are sitting on the patients that were there. It wasn't until I started to tell my nurse practitioner, is there no one out there that has stomach cancer? She said, oh, well, yes, but the cancer support groups are still closed. She did give me a number. I tapped into WeSpark, but that didn't happen until 2024, just this past year, in June. So I've been walking this alone with no cancer support survivors since 2020. So I'm really happy to have found you guys. I just found you. I had no idea where you guys were. It was obscure. I had no idea. So we need better advertising. We need better people to speak out, because I had no idea. You were all out there, and I really needed you in 2020. And I am just so sad that I did not know you were there reaching out for me. Because I didn't know to reach out. I didn't know you existed. But I know now. And you're stuck with me because I'm going to hang on to you guys and give other people hope.
Tell us your name one more time.
Doreen.
Doreen. And Doreen, give me a title to this story that you just told.
Fighter. Despondent. Warrior.
Fighter, despondent, warrior. Just a quick summary. So you were saying that you were diagnosed and during COVID, you felt alone. And you're also someone who believes, like the experts and everything, and through your treatment, they said that it was over. And then through the treatment, it's like, it's not over. And through that process, you were a fighter, and then you gave up, and then you were fighting again, and now you found community. Yes. Okay? I just wanted to, okay. All right, your name one more time.
Doreen.
Doreen. Slide over just a little bit so you can see, because we're going to watch your story come back to life. Ahmad is playing Doreen, everyone. All right? On the count of three, we're going to say, Doreen, let's watch. Ready? 1, 2, 3. Doreen, let's watch.
Fighter, despondent, and warrior. That's who I am. Yeah. That's who Doreen is. But I will walk down these empty hallways and I will look at the lone faces. I could feel their despair. I can feel the uncertainty. I can feel the worry that carried on these long faces. But I'm a fighter. And I'm willing to fight.
Miss Doreen, I have this for you. Can you turn your arm towards me? No closer, please. Just your arm, ma'am. Just your arm. Just your arm, ma'am. No closer. Thank you, ma'am.
I have a confession to make. I'm a fighter. I'm a warrior. But I hung up the gloves.
Yep. The cancer. Oh. The cancer is all over your body. It's all completely all the way through you. Every place you can look, every place we've looked, it's there. It's going to continue. But we can try one thing that will kind of help hold it in place for a while. But it's not going to go away. It's not a cure. That's the way things are now. I want to give you things clearly. I want you to understand. I didn't want to have any clouds in front of what's going on. You're full of cancer.
And I'm not going to let you go. No medication. No medication.
Grandma? Is it time for pumpkin pie? The turkey was so good.
Thank you. Sit down.
Okay.
I have to.
Are we gonna play a game?
Well, later.
I love your games, Grandma.
I have to talk to you about something.
Okay.
You know,
Mom, do you think this is a good time?
Yes.
Okay. I'm standing by if you need me.
Thank you.
Go ahead.
Yes, Grandma?
My lovely granddaughter. You know I love you.
I
right?
know. We're besties, Grandma. I know. You're a superwoman.
No lies. No lies. No lies.
I have cancer.
Doreen, there's hope. I know you don't see me yet. There's hope.
I'm fighting. I'm dealing with the ups and downs of having hope and then losing hope. But I'm fighting. And I want you to know that this may be the last time that you see your grandmother.
Oh, Grandma. I love you, Grandma. You're my bestie.
I'm very sorry. I have some additional news for you. Things are not working out the way we thought. I'm glad you spent time with your family and you've gotten your arrangements together. We probably won't see each other anymore. But I want to tell you this. I've been doing some research. And it appears to me you've taken everything I've said so seriously. I know I'm the doctor. And you're supposed to take me serious. I'm a believer. But you've given up. Even I want you to fight. In spite of what I see on the records. In spite of what the tests are saying. Get up and be that person that you used to be. Fight. I've watched you fight before. Fight to the end. Fight to the end.
You can
fight to the end.
To the end.
My friend.
To the end. Fight to the end. Fight to the end. You are a fighter. You are a fighter. Grab the hope. Grab the hope. You are a fighter.
There's still hope, Doreen.
You are a fighter. You are a fight,
You're right.
fighter. Fight. Yes, fight. Yes, fight.
I'm gonna keep fighting, everyone.
Yes, fight. Yes.
Because it's not over.
Yes, fight.
There's still hope.
There is hope.
And I'm gonna go down swinging.
Hope for stomach cancer. We're here. We're here. We're gathering everyone together. Come on.
Come.
Hello,
welcome.
Where have you been?
We've been here.
I've walked this journey alone for so long.
Doreen, we're here.
We're
Come
all
on.
here.
All
of us
We're here.
We've
been waiting
been through some of
for
the
you.
same
Doreen,
stuff.
welcome.
Come to hope.
We're here.
We are
My
here
community.
for
Yeah.
you.
Where have you been?
My family.
We are
Look
here
at us.
for
My tribe.
you.
Yes.
Powerful together.
We are here.
We've got you,
for
Doreen. We've got you, and you've got us. We're
We
together.
are here for you.
We'll help you no matter what.
We
We're
are
by your
here
side.
for you.
You are not alone.
No.
Here,
We
sit.
are here for you.
You know how that COVID was? Nobody could be with nobody. You're not alone now.
No.
You are not alone.
No one's wearing masks.
But we're gonna love on you.
We are here for you.
We're gonna love
We are
on
here
you.
for you.
We're gonna
We
support
are
you.
here
Yeah.
for you. We are here for you.
We
We're
can,
gonna love you.
we can see you're a fighter, too.
We are here for you.
I wish I met you
We
guys
are
earlier.
here for you.
Like, come
We
on.
are here
Like,
for you.
uh,
We are here for you.
so we're gonna fight together?
Yeah.
Fight,
Hey,
fight,
guess what?
fight.
There's a conference coming up.
Fight.
I wanna go.
You're invited.
Fight.
We're gonna be there
Oh,
together.
yeah. You're going to love it.
2020, 2021,
2022.
Long time.
2023. 2024.
2025. Hope is here. Hope is here. Hope is here. Hope is here. Hope is here for you.
Keep fighting.
Hope is here.
Keep fighting.
Hope is here for you.
Keep fighting.
Hope is here.
Keep fighting.
Hope is here for you.
Keep fighting.
Hope is here.
Keep fighting.
Hope is here for you.
Keep fighting.
Hope is here.
Look at that warrior.
Keep fighting.
Hope is here for you.
She's meeting all new people.
Keep fighting.
Wonderful.
Hope
Yeah.
is here.
Keep fighting.
Hope is here for you.
Look at her spreading joy.
Yeah.
Keep
Just
fighting.
smiling.
Look at her.
Hope is here for you.
Keep fighting.
Such a beautiful smile.
Hope is here.
Keep fighting.
Hope is here
So grateful.
for you.
Keep fighting.
So
And
grateful.
you
So
and you.
grateful.
Keep fighting.
And you and you and you.
Keep fighting.
And you and you and you and you.
Keep
and
fighting.
you and
We've
you.
got you, Doreen.
For
Right
you
here.
and you and you.
Keep
and
fighting.
You and you.
Keep fighting.
We've got you,
Hope is
Doreen.
here.
Keep fighting.
Hope is here.
I said, keep fighting.
Hope is here. Hope is here. Hope is here for you. Everybody in this room has hope. Hope is here for you and everybody in this room. Hope is here. 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 Hope is here for you.
Thank you, actors. In the moment, they're going to make eye contact with you. Thank you for your story.
No, thank you. Thank you. Thank you. You did what I could not express. You expressed what I felt. I don't know how you did it, but you did it. And you touched everything that I was feeling. So I just want to thank you, all of you. And you. Thank you.
Thank you. Thank you so much. Yeah.
Oh, you guys did an awesome job. Thank you guys so much. You did an awesome job. Thank you. Oh, you guys are awesome. Thank you. You're awesome.
So, raise your hand if you feel more connected. Look around. Look around. Hold. Keep your hands up, please. Continue these conversations. Continue to share your story. Continue to create community. Okay? All right. So I want to introduce this wonderful cast. We have Gregory. We have Pamela.
Yeah.
We have Ahmad.
Yeah.
We have Aaron.
Yeah.
We have Asali, our musician, wonderful musician. And my name is John Johnson. I also want to give the microphone over to Compassionate Coaching. Aaron, if you want to say anything real quick.
Sure. Okay, great. Thank you all for being here. This is what we do at Compassionate Coaching. We honor your stories. And we're just really grateful for the opportunity to be here 2 years in a row. So thank you so much for this opportunity. Thank you, Aki. We really appreciate being here. And we applaud all of you. So your lives have touched ours. So thank you. And if you want to connect with me about the work that we do, just come on up. We can have a conversation. Thank you so much.
Thank you again, Erin and the theater team, for joining us today. I know I wasn't prepared for that in the best way, and that healed me in ways that I can't describe right now. That was really cool. So we are now, are we doing a Q&A? No, okay. Yeah, so guys, we are done for the day. We just have some housekeeping for tomorrow morning. Tomorrow we will have breakfast from 8 to 10 a.m. Please come at your leisure. For those of you who are joining a focus group, those will be at 9 a.m. Amgen will be taking place in Van Buren, and Jazz Pharmaceutical will be taking place in the Monroe Room. Our session will begin here at 11:30 tomorrow morning. So for tonight, we are having our dinner and watching Taylor Swift up in the Sky Dome. To get there, at 6 o'clock, guys. Taylor Swift, 6 o'clock, Sky Dome. Focus group at 9:30. Guys, I'm done. Okay, to get to Taylor Swift, we're gonna walk to the North Tower, take the elevator up to the Sky Dome or to the 14th floor, and then the elevator to the Sky Dome. So, thanks, guys.